من قطر الشقيقة، وإن شاء الله بإذن الله راح يكون مؤتمر ناجح ونطلع بتوصيات عديدة. المحاضرة الأولى إن شاء الله راح نبدأ الآن علشان الوقت. راح يكون البروفيسور الدكتور بدر الغامدي. طبعا الدكتور بدر الغامدي غني عن التعريف. He is a consultant internal medicine and respiratory medicine, American Board, Canadian Fellowship. He is a professor and chairman, Department of Medicine, College of Medicine, King Khalid University, CEO, تشافي Medical Company أبها في المملكة العربية السعودية. دكتور بدر الغامدي إن شاء الله راح يتحدث عن lessons learned from the global crowd management conferences. دكتور بدر تفضل.
بسم الله الرحمن الرحيم، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. To start with, I would like to thank the organizing committee, Dr. Muhammad Al-Fayfi and his group for organizing this important conference, international conference about mass gathering and emergency medicine. His efforts really, I would like to thank Dr. Muhammad Al-Fayfi for his efforts and the group who are organizing this very important meeting about mass gathering and emergency medicine. I'm always happy that this meeting is in Medina. These really mass gathering efforts, we are proud that we see it in Medina and Mecca all the time. As you know, these two holy cities are actually hosting mass gathering events 5 times a day, all the time. And these two holy cities, they have really excellent and deep experience in mass gathering medicine. This is my, you know that I'm from Abha. I was before in King Khalid University. The main objective of this presentation is to give you some recommendations and guidelines, which I call them lessons learned from the global crowd management meeting and conferences around the world. As you know, the crowd management in general is by itself a science, as a crowd management science, and it is very, very closely related to mass gathering medicine. So it is strongly recommended that all personnel who are in mass gathering medicine should be aware of all the recommendations and the progress of crowd management around the world. In particular, as we know, that the vision of our Crown Prince, Prince Mohammed bin Salman, His Royal Highness Mohammed bin Salman, our lovely prince, that his vision actually is well established about the 2030 KSA vision, that we are looking to make our country great. And of that is that more and more mass gathering events are going to take place around us soon, that we will see it in our cities. Actually, the meeting itself, or the conference that we had actually all these circles that you see in the slides. Are you seeing the slides? Here, sorry. These circles actually are the future and the present situation of our country. As you know, Mecca is holding Umrah and Hajj all the time. Al-Madina Ziyarah, that we see it every day. And we are looking for more and more events that are coming around us, which is the Expo, which is the World Club, and others that are going to have more and more attendee from across the globe. And we will have a lot of crowds around us in these events. And we, as actually we are taking the lead in mass gathering medicine, we should be aware of the international and the global crowd management progress that is happening around us. This is actually the basic objective of this presentation, is to try to review some of the progress in the crowd management science across the world, so that we are aware of what's going on, and we should be having our like collective efforts with crowd management personnel and mass gathering medicine. It was not really easy task for me to go and try to get all the recommendations and guidelines about the recent crowd management administration and science. However, I chose actually 3 main resources that I thought are really great in the current global crowd management science. The first one is the Global Crowd Management Alliance, which is well established, started from UK, and it has a website, and they are actually establishing themselves in to be one of the pioneers in global crowd management. The second one is the Crowd Safety Summit that was held in South Korea, Seoul, in March this year. And there is another one which is called the Global Crowd Management Congress, which was held in February again this year. So these 3 resources had really good data that I will share with you in my presentation this morning. The Global Crowd Management Alliance, it aims, as really stated in their website, it aims to raise the standard of crowd management practices globally through education, advocacy, and motivating individuals and organizations to facilitate positive change in the global crowd management. So this is their actually vision, and this is really very important because it is well established and it can be an excellent source in crowd management guidelines and science. The same place underline that crowd behavior is influenced by social identity, and this is very important really. The social identity is very important to be studied deeply in every crowd management event, because the social identity, it will recognize that people will act in a way that the crowd management administration should be aware of the social identity of that place. And if you identify the social identity of the place and the groups, then you can design better messaging and interventions according to the social identity. So this is one of the lessons that we should be aware of, that people and groups in the social events that we are attending and we are organizing. We should study that deeply so that we can really have better management of mass gathering medicine and crowd management. Okay, another point, this actually organization is trying to stress is that the crowd management science should be a real science, and we should really stress all the efforts trying to develop the science across the globe so that we can achieve better and better research and development in this field. It is also important that we have to speak the same language across the globe, because there are some misleading terms that each place is adopting, and these terms actually may affect the science itself negatively and will not help in the global development of the crowd science management. So all international agencies are recommended to use the same terms and definitions, as we always stress on that we should use the same language, the same terms, okay, in medicine to facilitate the new development and intervention in the science and even in research, so that once we speak about a problem or a definition, that we all use the same definitions and terminology. An important point also this agency is stressing that we should really encourage clear shared responsibilities and joint efforts among international agencies, so that we communicate, we share knowledge, we share common situations and awareness, and we establish international zones and crowd behavior. This last point is very important, is that we should know the crowd behavior in each event. As you know, the events are different. And this is another point I will also ask, I will mention later, that the crowds and the events are different among each area. And we should study the crowd behavior in each area and each event, so that we develop and accumulate progress in the development of the control and management of these events. And actually they are even recommending what's called as international zones, that we can identify the zones and the behavior of each zones and how the crowd are actually behaving in each zone, recommending that the Middle East zone, till now this is not well established, but for example, Middle East zone, European zone, North American zone, so that we know the characteristic of each zone and the crowd behavior of each zone. And then once we are in that zone, we can have a better management and better control of that zone. So these are really very important messages that I'm trying to deliver to you in this topic, that I hope that we can really record it, keep it, and develop it, and make the joint cooperation between mass gathering medicine and the crowds across the globe. Another resource that I quote some data from is what I called as the Crowd Safety Summit, which was held in Seoul, South Korea, It was in March. Like that. And now you can't see the slides. I thought that you were seeing the slides from the start. They were not there. So I will go through quickly about what I mentioned before. So it will be good to see with the slides. I told you about our future here and the expected important events that we are expecting. And I told you the resources that I'm quoting my lecture from, the Global Trout Management Alliance, the Trout Safety Summit from Korea, and the Global Trout Management Congress, which was held in February this year. So these are the sources that I quote my data from. I mentioned the Global Trout Management Alliance and its efforts to develop what's called the trout science. And I emphasized the misleading terms that we should avoid in our meetings and in our language, so that we speak the same language between the globe. Whenever we go to any area, the same language are adapted and the same terminologies that we should use, so that we can have more and more development and intervention and research in the field of trout management science. And I started with the Trout Safety Summit, which was held in Seoul, South Korea, in March this year. And again, this summit really gathered good experience across the globe. It was actually mainly a joint effort between the University of Melbourne and the Institute of Science and Technology of Korea under the summit, with others actually who are also cooperating in this summit. And they came out with a lot of recommendations that I'm trying to actually summarize to you. The event itself was about trout safety mainly. It was an initiative established from Dr. Milad Haghani, who was a chair and founder of the Trout Safety Summit in the previous years. And he is from Melbourne, from Austria. And they were trying to transform and continue in the field of trout management science, and trying also to establish a platform for academics, government representatives, and industry professionals worldwide, so that they can intersect and they can share vital issues about trout safety. The summit was addressing mainly the critical need for reducing preventable deaths and injuries in urban settings during the trout events. And as you know, these injuries and mortality and morbidities of the trout people is our main interest in the mass gathering medicine. The summit also was designed as freely accessible platform for academics, government representatives, and others to share vital issues of trout safety. And also the summit was trying to understand the complex behavior of tourists in different events, including religious, sports, and other events. And they think that the complex behavior of each region and each groups or each group should be studied very well and whenever we try to help in these events. And as you know, as I told you, mass gathering medicine is one of the major important supports of these events. And we should really follow and study deeply the behavior of our groups so that we can manage them well in these events. Another points are what's called as crowd dynamics. The dynamics of the crowd should also be studied well in research, and they actually made the example of the era of COVID-19 pandemic, that they found really a lot of challenges and opportunities during this era of COVID-19 pandemics in different areas. Not all, although we are all people and originating as human beings, but each zone, international zone, behave differently. And we have seen really the mortality rate is different from one area to another, although it is the same disease. The degree of like isolation and the degree of like that was affected, the healthcare systems were also different. It is not the same. Like Europe, they behave the same, different. North America were behaving different in the COVID-19 pandemic. Why they were behaving different? Because they are different group and they are different human beings. And we should study the dynamics of each zone so that we are aware of how we can protect them and help each zone in the way that they like. So this is important point and important lesson I'm delivering, that the crowd dynamics are different among the international zones. The submit again stressed the point of the crowd science that we should really develop, and its growth and its research, so that we can establish more and more data in crowd science. The important point, which also they stressed, is that monitoring and adjusting and obtaining feedback from each event is very, very important, that we should look at in research and development. Like whenever we have an event, we should have continuous monitoring of this event. We should have adjustment before and after each event to adjust our regulations, okay, depending on the feedback that we take from that event. So this is again another important lesson, that after each event, we get a lot of data and gather a lot of data for analysis and monitoring, so that the second event is better than the previous. So another good lesson that they actually delivered to us that we keep in our mind. I know that we are doing our best here. I know that the Hajj and Umrah Institute in Mecca actually are studying this and monitoring. And this point was stressed here in the summit, so that monitoring, adjustment, and feedback operations should be a continuous process all the time. The combination of efforts should be always kept in mind in these events between engineering, human factors, data science, and public policies with medicine. And I will add medicine here because really we are from mass gathering medicine that we should be part of the respective combined efforts in each event. That is very important to go through. The summit also addressed the importance of vulnerable groups and population in the crowd, ensuring that these individuals are not left behind. Very important point that we should be addressed. And we should always incorporate vulnerable groups' behavior among the crowd management so that we can adopt access and address pathways for these people who can be slower than others. These are the disabled attendees, elderly, and children. These are different groups that mass gathering medicine and crowd management should adopt their own policies. They are different groups and they should not be left behind. And each event administration control should address this point clearly and make sure that there are special needs for them so they are not left behind. An important, very important message from this summit about these groups that we should not forget and we should always keep in mind. The summit also addressed the environmental factors, the weather changes, the air quality, especially as addressed to the vulnerable groups and people. That we always keep the environmental factors as an important, very important point to address in each event. The climate changes and the climate impacts as heat waves or smoke should always be kept in mind of the control messages. It seems that I'm exceeding my time, so I will try to be quick. Again, we stress the importance of evidence-based guidelines, identify gaps, especially in the respiratory, cardiovascular, and the infectious diseases pattern. And we try always to link public health, clinical practices, and the operational planning between the in all mass gathering events. The air quality monitoring, alhamdulillah, we are doing now in Al Haramain, that we always stress on air quality monitoring. And we should also address the quantity of dust and smoke around the crowds. And we should always address the disease transmission, the crowd density, ventilation, and mask use and vaccination. Very important message, I stress on it again, that not all mass gathering events are the same, that not one size fits all. So if we are a group here now in mass gathering medicine, attending a stadium sport, we should think differently than attending the haram area. It is not the same. Although we are speaking about events, we are speaking about mass gatherings, but mass gathering in the stadium and the crowd there will behave differently than the crowd in Al-Haram or Al-Hajj area. So always, all plans should depend on the social background of that event and the behavior of the people there so that we can have better outcome. There are different models also that we should keep in mind. The Hajj model, Olympic models, and WHO models, they addressed each. And now we have the models that are well established and well written that those who are in the field should study these models well before we go on. This is an important point about AI. The meeting addressed that we can actually catch. They gave example like cough, shortness of breath, and fever. We can catch by surveillance, camera surveillance, and these will be an important point during the drought, so that we can really pick up these people across the crowd, and we can try to help them earlier before they collapse or they make more problems. So the syndromic, what they call it, syndromic surveillance cameras should be always think about and put in the research and the development. The gates, we always stress on gates, and they think that pulse oximetry and other symptoms can be included in the gates, so that these gates can discover the health problems early in the droughts. So in conclusion, the drought management is a continuing experience that needs global cooperation with standard guidelines, sharing experience and feedback. It also deserves international attention and continuing education and science research. This is what I thought is important in this topic. I hope that these were useful. I'm not sure about the questions, most likely will be later. Questions later. Yes, so thank you, and I was happy to have you all with us today.
Thank you, Dr. Badur, for your talk. The second lecture is going to be business strategy for mass gathering, which is going to be provided by Professor Saeed Al-Ghamdi. So you are welcome. Prof. Saeed Al-Ghamdi is a consultant, fracture surgery, associate executive director of the training SCH, fifth sectors, farmer chairman, technical supervisor committee for hospitals and pharmacist care center in the holy city Al-Mashair Al-Muqaddasa, Riyadh, Saudi Arabia. You are welcome.
Assalamu alaikum wa rahmatullah. It's my pleasure to speak with you today about the healthcare system during Hajj 1446, which correspond to 2025. Every year, millions of pilgrims come together in a very short period of time and in a very limited space, in very challenging conditions. This creates one of the greatest tests while managing the pressure of huge care, safe, accessible, and free of charge, while managing pressure of huge crowds, heat, and emergencies. In this presentation, I will share how the integrated health model worked during Hajj 2025, how it saved lives, how it lowered costs, and how it was designed to handle these massive challenges. I will also touch on the adaptations for large crowds, the financing that ensured healthcare which remained free, and finally the clear metrics and actions that will guide us in the next season. Let us begin with the background. This year, more than 1.67 million pilgrims gathered, which is far more less than the year before. The year before was around 3 million, all concentrated in a very limited area. That density of people created unique health challenges. On top of that, the conditions were extreme, the temperature rising above 45 degrees Celsius, combined with continuous high density movement of the crowds. Despite these challenges, the healthcare system delivered nearly 200,000 services, covering every level of care, from simple clinic visit to highly specialized hospital treatment. And most importantly, all of these services were provided completely free of charge, ensuring that every pilgrim received high-quality healthcare without barriers. Hajj healthcare is not just about serving pilgrims. During few days, it is part of a bigger national vision. The strategies we see in Hajj 2025 are closely aligned with Saudi Vision 2030. They reflect the goals of Health Sector Transformation Program, which focus on building strong, resilient, and integrated health system. At the same time, they advance the Pilgrim Experience Program, ensuring that every pilgrim receives safe, seamless, and dignifying care. In other words, the success of Hajj healthcare is not an isolated effort. It is a living example of Vision 2030 in action. Now, a quick comparison of Hajj 2024 and Hajj 2025. Last year, the system mobilized over 32,000 health and administrative staff. This year, we scaled to more than 50,000, a major step up in frontline capacity and coordination. On beds, on 1445, which is 2024, provided over 6,400 beds across hospital and field units. In 2025, we expanded hospital bed capacity by about 60%, ensuring faster admissions, better ICU access, and shorter waits during peak hours. So, year on year, we did not just add people, we add surge, readiness. This is the backbone of the outcome I will show next. Let us look at the official Ministry of Health metrics for Hajj 2025. This season, the system delivered close to 200,000 health services, covering everything from complaint visit to advanced interventions. More than 5,000 pilgrims received life-saving emergency and critical care, including cardiac catheterization, open heart surgeries, and treatment for severe heat strokes. On preventive measures, over 500,000 vaccinations and screening were carried out before and during the season, reducing the risk of outbreak. And importantly, thanks to the digital systems and rapid deployment, the response times for emergencies were cut significantly, showing how readiness translated directly into saved lives. In Hajj 2025, several strategies stood out. not only because they worked, but because they can be scaled to future season and even to other mass gatherings. Around the clock virtual first triage and electronic referral system was operated by multilingual teams with clearly defined volunteer roles. As a result, unnecessary transfer were reduced, emergency departments were preserved for the emergencies, and patient navigation was streamlined. Pilgrims reach appropriate specialists more quickly. Overall, safety was improved and repeat visit for the same issue decreased. A modular hospital was established within 30 days at the Kidana project in Mina, supported by field deployment readiness and vendor pre-contracting. This approach enabled rapid surge capacity and maintained reliable continuity of services. An integrated command between Ministry of Health and the Red Crescent was activated, backed by real-time syndromic surveillance and clear escalation path. The effect was coordinated decisions across agencies and faster incident response at every site. Though pre-event vaccination and real-time monitoring, the system successfully reduced the spread of infection. This means lower transmission rates and, importantly, fewer visits to the clinics and emergency department during Hajj season. On-site cardiac catheterization and open heart capability were provided, enabling faster treatment. Consequently, mortality was reduced and complications were lowered. The Saudi Food and Drug Agency monitoring and inspection across the supply chain were implemented and mobile testing points deployed. Consequently, food and medicine incidents were prevented and outbreak risk was minimized. With air ambulances, helipads, and key sites, and pre-planned transfer routes, critical patients reached definitive care within minutes, and that delivered clear survival benefits. Here, what was observed in the field this season. Access improved. Time to triage and to the clinician was shortened and navigation was smoother. Capacity preserved. Unnecessary transfer were reduced, so emergency departments were kept for through emergencies. Critical care faster. Heat emergencies were called sooner, and cardiac patients were refused earlier, leading to lower complications and death. Safety strengthened, food and medicine incidents were prevented, and outbreak risk was minimized through vaccination and real-time monitoring. Continuity ensured. Modular surge hospitals were activated, keeping services reliable during peak hours. Equity protected. Care remained free at all health care levels, including high-cost treatment. Fewer returns, repeat visit for the same issue declined. In short, speed went up, risk went down, and every pilgrim kept free access to high quality care. During Hajj 1446, bedside care was free for every pilgrim. Public funding covered everything from cardiac catheterization and open heart surgeries to heat stroke treatment and emergency interventions. The commitment was simple: equity, safety, and timely access for all, regardless of background, income, nationality, or insurance status. To improve cost benefit, a small bundle of low-cost insurance cover can be added. These include a visa bundled cover, parametric heat insurance that pays out when temperature spike, stop-loss reinsurance for rare high-cost seasons, and short post-Hajj continuation cover. Together, these add-ons cost about $40 to $70 per pilgrim, roughly 8 to 15% of today's cost base. Why do this? It shifts demand toward prevention, adds liquidity during surge, stabilize budget in unusual years, support continuity after Hajj, and preserve free bedside care during Hajj. In this 2025, the areas generally excellent, the triage and clinician response, vaccination coverage, complaint handling, safe transfer, no major outbreak reported. This is the recommendation is to strengthen heat care protocols under extreme climates. Even the coming season are colder, but to make a base for the next season of heat, expand virtual and first aid triage system, standardize data capture and reporting on efficiency and outcome, and invest in experience and value measurement tools. In conclusion, in Hajj of 2025, an integrated model was proven to work at scale with virtual first triage, surge hospitals, integrated command, strict regulation, and air-ground evacuation. Time to treatment was reduced, preventable risks were lowered, and complex care was delivered free at the bedside. The approach saved lives while ensuring resources more efficiently, showing that quality, speed, the equity can go together. Financing was secured through public funding with optional visa bundle and parametric protection, adding liquidity. Free care remained unchanged. For the next season, success will be measured by faster triage and cooling times, early cardiac reperfusion, safe transfer, stable occupancy, fewer readmission, and better patient experience. In short, a value-driven system was demonstrated, and it can be scaled for bigger crowds and harsher heat. Thank you very much.
Thank you, Professor Badr, for your speech. Now for the third talk about the digital transformer in major incident disaster management, which will be profiled. Now the third talk is going to be about digital transforming in major incident and disaster management. Lecture from Professor Professor Abu Hassan Abdullah. You are welcome. Professor Abu Hassan Abdullah is a former founder of the head of the emergency medicine and tumor surface safe sensors, academic of the medicine Malaysia, council member, Malaysia Medicine Council, chairman committee for the preparation and guidance of the regeneration medicine and stem cells research and theory, visiting consuls, emergency department of the hospital, Kuala Lumpur, Ministry of the Health, Kuala Lumpur, Malaysia. You are welcome, Professor.
Thank you. Thank you very much. Bismillahirrahmanirrahim. Assalamualaikum. And very good morning. Thank you very much for the organizing committee for inviting me to be here. MashaAllah and Alhamdulillah. I've never dreamed to be able to give a lecture in this ibadah environment. I've been coming to Medina and Mecca for almost 30 years. And during Ramadan, every year I come. And I never dreamed to give a lecture. And this is the first time. Thank you very much again, with greatest pleasure. Now, first and foremost, let me just introduce myself again. Oh yeah, by the way, I'm so happy to see some of my friends, Dr. Wahab Musleh, and of course, all my children who studied in Malaysia, from Sudan, mashallah. How come you look younger than me now? And most importantly, to everyone, I just want to say that my sharing today has got a lot already been mentioned, but let me just share my experience. And this lecture is entitled Digital Transformation of Major Incident Management. Now, let me just first mention that I am in many portfolio, but the one that's related to this is I'm an advisor to the Center of Artificial Intelligence and Robotics in one of the university in Malaysia. I have started emergency medicine service in Malaysia, also in Indonesia, and also in contributing in many countries. And I have retired since then. And then I joined many corporate companies, and I'm a chairman of a few companies. But anyway, let's just go into this issue of the digital world. Every one of us are already in this ocean of digital technology. And there are already so many benefits. And digital transformation in healthcare have done a radical change in the delivery system, enable and facilitate, and it is by the advanced digital and mobile technology. Definitely improve performance, efficiency, and accessibility. Now, advanced digital and mobile technology revolution with artificial intelligence is something that is of no deny. It has to be adopted as one of the systems that we can benefit from. But before too long, let me just remind everyone that I actually wrote 2 books on reminding us that despite all the benefit of the digital world, we also have to be aware the issue about digital dependency, digital addiction, and it will impact the future. But I'm not giving that lecture today, but I wish I could share with you all also my concern about digital dependency and digital addiction. Now, in Malaysia, my sharing today, just to tell you that the Malaysian government is so aggressive in bringing digital technology to transform our delivery system in many services. And we have promised that one person, one record in all the citizens of Malaysia, in our identity card. And this have been a plan that have been there for a while. And there are a lot of activity on digital transformation in Malaysia. And of course, one of which is what I'm going to discuss with you all today. Now, this idea about the telemedicine vision for healthcare in the healthcare goal in Malaysia, facilitated by digital technology, have been there since 2005. And there were all these pillars that we promised the citizen of Malaysia to have to benefit from. But I must confess that the movement of the digital technology is too fast. In fact, I'm also the chairman for the regulation of AI in the medical school. I'm not able to regulate because it moves so fast. And in fact, ChatGPT and AI dependency is so great, in so much so that the regulation have to move as fast as the technology. Now, Malaysia, of course, been driven by 5G, and there are many initiatives. So let me just focus on one of the things that we are discussing today. And I wrote a paper called Uberization of Healthcare, of which there are so many components, and one of which is digitalization of disease prevention program. And of course, digitalization of major incident and disaster management. If you look at this ecosystem, this so many components of which in the Uberization of healthcare. Uberization of healthcare is as simple as bringing healthcare to the doorstep. In the previous presentation, I must congratulate the healthcare system in this country that have done so well in managing mass gathering. I'm one of the beneficiaries, and I've seen even how Rauda have been controlled. Yesterday, I went there. Oh, very nice, much more better than stampede and pressing each other's chest. So yeah, I think it has done well. But however, let's look into one of these components. This is what we call the disease control with artificial intelligence, which I will discuss in a while. Okay, some of the, you see what we have, as you all know, we have the communication technology and communication highway. We have also system, gadgets, and everything else. Now, the influence of this have to be balanced. Nowadays, the young use it for TikTok, for IG, for everything else, and the influence bypass the role of parents and bypass the role of teachers. So we in Malaysia have to identify application that give meaning to our country and have to give more meaning. Precisely, I have proposed many of this digital transformation in healthcare and to create some of the benefit which is more meaningful rather than the ocean of technology that take our young into the world of fake and everything else. In fact, we said now there's no moral, there's only viral, you know. So whatever that come out in the media seems to be the truth rather than the real moral values. I keep reminding myself about this simply because, yes, we benefit from it, but we also have to be. Let's then focus on the topic today, digital transformation of major incident. Under the fourth industrial revolution technology, we have artificial intelligence, we have machine learning, we have nanotechnology, Internet of Things, and of course, drone robotics, internet autonomous vehicle, self-navigating drone, home robotic, information and target attack, robotics and blockchain and data security. Well, there are far too many things to discuss, but I would like to touch superficially on some of the things that we have done in our initiative. As you all probably know, artificial intelligence is so significant in its influence in our life today. And it's all about taking over some of the function of human. But I think we have to be cautious on that, but I have to remind me and also every one of you that artificial intelligence is not all truth, nothing but the truth. And there are a lot of the good and the bad of artificial intelligence. Like I said, I keep reminding, the weakening of emotional intelligence, digital addiction, reduced capacity of cognitive function, and memory is something that we all have to be bear in mind. Now, of course, data security is very important. And now we have to blockchain it to encrypt, because even data from the healthcare data, which is so precious and so private, has to be blockchain. Otherwise, it is hackable. Let me also remind everyone that the black market in data sale are very, very lucrative. And if you don't blockchain your data, some people can sell the data for good money. In fact, now it's probably more precious than gold. Yeah, so towards data security, blockchain and encryption must be done. Now, there has been a significant improvement in the management that have been achieved with the digitalization of various systems and processes. New technologies, example, artificial intelligence, automation, cloud solution, real-time analysis to shift from reactive problem solving to proactive risk management. Really, we have to invest our money, time, and effort in prevention strategy. Now, several new equipment, instruments that have been deployed for total management system, especially in the search and rescue technique, for example, drone robotics, which I will discuss in a while. Now, I think the issue about digitalization technology, there have to be a work process transformation. We have seen some that have been done in the management of the mass gathering in Hajj. Congratulations. But more work process transformation can be benefited from the technology. Now, enabling technology, gadgets, software have been there. I'll be sharing with you all some of this initiative that we've done, especially during COVID time. And of course, communication and connectivity, without doubt, enable us for universal coverage, and of course, many initiatives that actually be supported by technology, communication technology. So, preventive strategy is so important. We have to be proactive and using AI, satellite imaging, global positioning, global identification system, remote sensing, and all these are some of these systems that's available for disaster risk management. We have some initiative also in countries like the Philippines and also Indonesia, which I'm also an advisor to these two countries, looking at how what we call disaster risk reduction. And there's a big, what we call guideline for disaster risk and early warning system and so on. Now, preparedness, contingency planning have to be supported by digital technology. Focus on incident site management. I will deal with it in a while. And hospital activation phase, and of course, recovery phase. Some of these components are already being fully supported by digital technology in the management of major incident and disaster. Now, in the natural disaster, as you all probably know, some countries are in the seismic belt and in the ring of fire. The Philippines, Indonesia, and in our part of the world, Japan. Now, we have now a very effective early warning system. And this is for disaster risk reduction. So I'm not going to give a lecture on this, but as you all probably know, that there are many systems that can detect to evacuate people from the place where they are staying. But I must confess, it's easily said and done. When I was in Indonesia, we have an early warning system. But when the people are living there with their vegetation, with their work and all that, you ask them to leave, they would not want to believe the early warning system and they still stay where they are. So despite all the technology, there are still some challenges. Now this is when I was in Indonesia, you can see that they are in the seismic belt and all the features of the ring of fire. Now, of course, in my part of the country, of course, we have what we call the dark side of modernity, more complex and widespread and large-scale losses due to increased technology, increased urban development, greater area of habitation, sophisticated transportation, increased motorization. So they said in Malaysia, we don't have natural disaster, we create our own. So how do we manage that? Now, since the world is changing very fast, more people are becoming vulnerable to major incident and disaster and are forced to cope with the act of violence, financial crisis, and everything else that actually have a lot of impact to our livelihood. So we have, as I mentioned, some of this technology that enable us to reduce the impact of disaster, what we call the risk enhancement factor. We already know that the climatic changes, the global warming, affecting the environment, the shrinking of the glaciers, and so on. All this have created enormous change to the vulnerability of human population in some part of the world. In fact, last year I was in Oxford. My son graduated, and there was flood in Oxford. It never heard of that happen, and they were saying this got to do with climatic changes. Like I said, it's so unpredictable. Now, the risk enhancement factor, again, with the globalized economic development, increased human vulnerability, poverty, inequality, and so on and so forth. Now, weak governance are also an issue. Now, we know very well, this is something that every one of us have to be fully aware. With viral mutation, antigenic drift, antigenic shift, influenced by pollution and everything else, we have COVID, we have influenza, and we have many. So the lesson that we learned from COVID, whether it's real, man-made, or whatever, the impact is really a very violent virus. So for this initiative, we have benefited from some technology, enabling technology. Let's look at some of this digital transformation that can assist in preventive strategy. Now, climate change mitigation, disaster response coordination, seismic activity prediction, forest fire prediction, flood prediction and management, landslide detection, early warning system are some of those features that already been created in many of these countries. Like I said to you just now, that some of this preventive strategy has already been implemented. Now, in the climate change mitigation, for example, applying AI for analyzing weather condition to predict the disaster, geological and meteorological and hydrological and climatological system detection. AI in seismic activity prediction. Machine learning model can analyze historical seismic data, monitor ground movement, detect subtle changes in the earth crust to anticipate seismic event. Now, this is very interesting in country with the ring of fire. While disaster may not be preventable, early detection can give precious seconds or minutes to take cover and reduce casualty. I think this is of no-brainer. In Malaysia, of course, we have fresh floods. We have many what we call man-made incident and disaster. Many road traffic accident. Just to share some, what we create our own mass incident. And so many, yeah. This is what happened in Malaysia because people drive very fast and some of these vehicles are not well managed, not well maintained, a horrendous accident in the highway. So, when people's lives are at stake, we cannot afford to make mistakes. So, reliable information and precise information will always be important to make us really effective in our life-saving organization. Henceforth, we must make really good benefit from digital technology in order for us to reduce the impact of major incident and disaster. Now, some of this strategy in the contingency planning, which is important system that we should have in country where disaster is part of their life, have to be done and have to be regulated. Situational analysis, with knowing the vulnerable human population that's around where the incident can happen. Risk analysis, assessment and mapping of the risk. Capacity analysis must be done. Risk communication, explain to the government, to the stakeholder, and explain to the people, and explain to all the corporate system that already in the country that can make enormous impact. Now, we don't want to really manage the destruction. It's better for us not to let it happen. So, resource development, matrix, capacity building, resource development using this new technology is very important in our contingency planning. Now, focus on emergency response, alert alarm system, response system. We see in the previous presentation, this have been done and many can be done. Of course, Finally, of course, to skill development training with tabletop exercise simulation is very important. Now, I was at one time the chairman of World Health Organization way back in 2004. We already talked about what can happen in countries within the Ring of Fire using technology as early as 2004. Well, if some of you may know this about the Sendai Framework for Disaster Risk Reduction, if you study and look at the document, they are also already mentioned about the use of technology for the purpose of reducing the impact of disaster and also major incident. Now, in Malaysia, I wrote this guideline for the National Security Council of Malaysia, and there are some of this system, which I will not go into the specific, that's already been established, the alert system, the communication system, and of course, one of the things that I also talk about, the data management and documentation using blockchain. And of course, later I'll touch a bit on psychological management, on the psychological first aid and critical incident stress management. Because some of this strategy already in place. Now, if you look at some of this technology that's already there, the use of snake robot for search and rescue, and the use of search drone, and drone for surveillance, and drone into high-risk environment. And I think this is really important. In fact, we have done some initiative where I'm actually advisor to this Center of Artificial Intelligence and Robotics. We create robot that can go into the house on fire or high-risk environment. Now, let me just try to emphasize the point about data security. All the data that we have must be secured because it can be shared and something which is not favorable for our management. Now, of course, the digital transformation major incident key benefit will be enhanced service resilience, improve incident detection, rapid and better response time, better communication and collaboration, enhance analysis and predictive insight, of course, more resilient services and improve outcome. So just to mention a bit more on for the ambulance service, we have this initiative called the digitalization of ambulance service. I don't want to go into the specific, but ambulance system have been improved with the use of cameras, with the use of data telemetry, data transfer, and of course, information given before even the patient arrived to the emergency department. And we've done this in Malaysia, not fully yet, but some initiative already started, ambulance with ability to transmit video, data, and so on and so forth. So this is what we call digital and computerization of ambulance with the innovation that we have managed to did pilot work in some, and in fact, some introduced already in some of our system with all this here. Well, just to mention, when during COVID, these were our initiative. We put patient in the hotel, which have no occupant. So we manage them in hotel, and then we have patient mobile app for COVID patient management. We have virtual consultation, telemetry and data transfer, store and forward and real-time consultation. We have self-care co-management system with unobtrusive biosensors with home monitoring. And of course, we have the middleware for triage center for data evaluation with artificial intelligence. And of course, we also have mobile doctors data management tablet and e-prescription and home delivery. Now, as I was saying, because hospital is all overwhelmed, so we open up quarantine center in hotel. Well, in hotel, easier for us to manage. We create a call center and we have them given with them some of this digital, their mobile app. And we have wearables. We give them some of these biosensors, which they can put in many places, you know, it's like a smartphone apps. This is the unobtrusive biosensors using infrared sensors that we give to all the patients in the hotel, and we can record their blood pressure, their oxygen level, and the vital sign, and so on and so forth. And it can be transferred to the call center for all the patients within that hotel. And of course, there is this another biosensor that can be used to detect their temperature and so on and so forth. And I'm not going to go into the specific in the interest of time, but I must confess that it has benefited us. So a bit on the summary and the conclusion on digital transformation of patient care in the major incident management. I think the mobile app for One Malaysian Fund Lifetime Record will be very beneficial. Hopefully, when there is a disaster, then we know already the background. With the QR code, we know the patient's health status, and within that, we can manage the patient better. And of course, with the preventive measures, we have disaster risk reduction, and we have disaster prediction, and we can develop a proper contingency planning. And of course, we also hope that with the clinical information, we can deal with the patient much more and reduce the impact. So, ladies and gentlemen, it has been a great pleasure for me to be here to attempt to share with you my experience. I hope it has benefited. And of course, if there's any more further information that you would like to have, I'm ever willing to share with you, inshallah. And thank you very much.
Assalamu alaikum. Thank you very much, Professor Abul Hassan, for this interesting presentation. Actually, we'll continue our activity. Because we have time, actually, and Dr. Abdul Wahab Al-Muslih, he will present soon. They are preparing the presentation, the slides on the computer. And just to let you know, we'll have 2 lectures now, and then we will start our opening ceremony, okay? And to save time, since I think if we stick to the schedule, yes, for sure, okay. Because if we stick to the schedule, I think we will finish by 5, 6 o'clock, but we will try to move faster, okay? So hopefully we will finish today by 4 o'clock. If this is okay with you. If there is any questions for the previous 3 lectures, we are ready. Any questions for Professor Abul Hassan, for Professor Al-Ghamdi, for Professor Saeed Al-Ghamdi? Any questions? Oh. Yes, go ahead, please. أعطي السبيكر الميكروفون. We need the microphone, please, here. If you could please, your name and to whom you address your question, please.
Myself, Dr. Muhammad Jasimuddin, pediatric specialist of pediatric ICU.
Okay.
My question is from Dr. Saeed Al-Ghamdi.
For Dr. Saeed Al-Ghamdi, okay. Go ahead.
Why they are not including other ministry like National Guard, King Faisal Specialist Hospital, and other ministry? They are also sending their medical team for the care of pilgrim of the Hajj. They have included only Ministry of Health. So entire cost and effort of the kingdom is not coming to us. When you include all the ministry, their team, their cost, then the total picture of the health care of the kingdom can convey very easily.
Thank you very much. The doctor is asking why the statistics and metrics are just only Ministry of Health, despite there are other services. Yes, there are other services like in every group or with every country, there are doctors. They are dealing with the simple cases. The Ministry of Defense, the National Guard Hospital, they deal with mainly with their military personnel, despite that we are serving anyone who is nearby to them, but it's not included. They don't share in the digital system. 937 is only for the Ministry of Health, which supported the Hajj more than any other integrated system. So just Ministry of Health is the one measuring their statistics, and the other, most of their work concentrated for their belongings. This is the reason.
And every country from pilgrims are coming. They are having their own medical team. That also should be included. So the total facility of the medical team for the Hajj should be in front of us.
Yeah, if I include what you suggested, my numbers will go double, which make my presentation better. Uh-huh. So I'm just presenting the Ministry of Health. Thank you very much.
Any other question, please, from the audience? No question, huh? Okay. Now it is my pleasure to introduce Professor Abdul Wahab Al-Musleh from Qatar. He's a project advisor for the medical director at Hamad Medical Corporation. He's a chairman of the board of the Qatar National Anti-Doping Agency. He's a member of Medical Anti-Doping Committee of the Olympic Council of Asia, Doha, Qatar. Dr. Al-Musleh will talk about Ministry of Public Health preparation for the major event. It's in two parts, so he will talk about it. Thank you, Dr. Musleh.
Thank you, Dr. Mohammed. First of all, I'd like to thank the organizing committee, especially Dr. Mohammed Al-Fifi, for inviting me. The second time I attended the first conference here in Medina, and it was a pleasure being part of it at that time. I'd like also to thank Future Vision for organizing such an important conference. It's clear that there is a lot of development even in the organization and the topics presented. You can see many varieties of the topics discussed in this conference. I'll try to be fast. And save some time. Originally, I've been given 1 hour to do 2 talks. I hopefully will finish both of them in half an hour if possible, or even less, to gain some time and have better time for the breaks and so on. I'm glad to see in one of the slides of Professor Abu Hassan the slide he put about the strategy for which are enabled by digital information. And I'm sure the AI is going to change the world and change us in the future a lot. It's just the beginning of what we currently see, and we are only seeing or utilizing the tip of the iceberg. AI is going to transform the whole world. This is for sure. As more applications are coming into effect, it's going to affect every aspect of our life, especially in relations to crowd management, sport events, disaster management, risks, emergency, and so on. We will see so much. As of now, you can see encroachment of a lot of AI tools into the medical arena, with tools supporting the physicians, but this is going to change entirely in the next 5 to 10 years. I'm glad to see the slides of Professor Abu Hassan about the strategy enabled by digital transformation, when he talked about the situation analysis, risk analysis, capacity analysis, and mapping. risk communications and so on. This is exactly what we did in the years prior or preceding the FIFA World Cup 2022. I was consulted in 2018. At that time, of course, we did not have AI and did not have a lot of intelligence, but it was used to be, as always used to be done, classically and manually. But we were consulted as part of the risk analysis that has been done before and the capacity and so on. Many of these risks and the capacity have been detected before the FIFA World Cup. However, nobody anticipated at all that an epidemic will hit the world and it will, of course, definitely affected the sports event. So in 2019, I was then appointed as in charge of the healthcare services for the FIFA World Cup. So I had 4 years, and I was impacted heavily by the COVID-19, which entirely changed the way we look at managing a sporting event. We did it very, very successfully as we developed special protocols for the event that have been implemented in the years before in all the test events that we carried out. We had several international test events. We did not stop any event. We carried all the test events, and we did not prevent, like many countries, spectators from attending. But we had a very controlled, well-controlled environment where we did testing, the COVID-19 testing for everybody, all the people involved and even the spectators. And we had controlled, of course, we gradually increased the percentage of people attending the event from 30%, 50%, 70%, 90%. And then when the World Cup arrived, we did it with 100% capacity. What's interesting is during these test events and the FIFA World Cup, the sport environment maintained a much lower incidence rate of COVID-19 than the rest of the country. You know, we had a certain level in the country, but the sport family and the sport event itself and within the spectators and within the residences of the players and so on, we had much, much less than the national level. As you all know, of course, that this event is the second FIFA World Cup in Asia, the first in the Middle East, and of course, the first in Gulf region. It was then the largest event in terms of spectators, at least, hosted in the country. We had previously in 2006 hosted the Asian Games in Qatar, which is a big event similar to the Olympic Games in terms of the number of sporting events happening. However, the number of spectators is much, much less than as anticipated than FIFA World Cup. We had so many challenges, and these challenges were heightened and increased because of the pressure on the country, as people, and especially in the media and in the West especially, have announced even before the start of the tournament that this event has a big fail, which of course we proved that their impression of us and of the country was totally wrong, and we were actually ranked the best FIFA World Cup organized until now. And many of the things that have been done, I don't think cannot be matched again in any FIFA World Cup. There are special circumstances. The country is small, the distances The stadiums are close to each other. Spectators can attend even 3 matches in one day, which I personally experienced. I attended 3 matches in several of the day of the tournament in one day, going from one stadium to another after finishing the match and so on. So there are so many things that cannot be matched again in the world. From healthcare perspective, we provided a state-of-art healthcare services that also I don't think that it's going to be matched soon because of the situation and how the organizing committee, with the support of the Ministry of Health, have made the FIFA World Cup and the participants, whether they are the family of the FIFA, the players and so on, or the spectators, as the core of the healthcare services during that period. But with one principle, as I will going to mention it, without affecting the national healthcare services. That was one of the major principles that we have undertaken on ourselves to achieve. And we did it very successfully. The other thing is we have, I have decided that we will limit to strictly the resources to the resources available within the country and limit the people who are going to support us from outside. So we only recruited from outside to ramp up the ambulance services to cater for the 1.4 million spectators that visited the, or the fans that visited the country. We had several partnerships as the Ministry of Health and the Healthcare Services of the Organizing Committee with many partners, including WHO, FIFA, Ministry of Health, and so on, in what we called a Sport for Health. And there were 3-year programs enhancing and promoting health and sports, or health and sport in the country and beyond. As I said, there were several principles. One of them that we ensure continuity of the routine medical services in the country, but provide and cater for the FIFA services as per their requirement. In fact, we have exceeded their requirement. We have in the country what we call Qatar standard for sporting event, which in many instances exceeded the minimum requirement from FIFA. The healthcare services included all aspects of healthcare services, not just the urgent care, primary care, that is a minimum requirement for such events, but also included public health, food safety, drugs, importations, and so on. And at that time, which is going to be happening again, even if a sport event happened in Qatar, probably, we provided all the healthcare services free of charge to everyone. We used to, all the spectators, anybody carrying accreditation, which means he has a ticket to attend a match, would receive healthcare services free of charge. We set up several layers of governance. So we had the healthcare services under the organizing committee, but we had several governance layers in the Ministry of Public Health as well. So all were collaborating to provide state-of-art healthcare services for the country during the event. Some of these statistics have been shared before. You may have seen or heard about them. We had about 50,000 patients treated encounters in total to any healthcare services. We had about 113 medical clinics distributed in all the stadiums, sporting and non-sporting sites. We had more than 200 mobile teams scattered around the venues, especially the sporting venues. And this helped us to be on top of any individual incidences happening during the event because they are close. So for example, I give you an example, by the way, we had 3 mortalities, 3 deaths during the November, December of that year. The 3 of them, one was crush injury by a heavy object falling on a worker in a resort. The second was a fall from height for a drunk security person in one of the stadium. And we had a CCTV on him before and after he falls. So we identified that he was not in his best shape. And I think that was because alcohol was allowed outside the stadium. So probably the security guy had drank too much before he goes to work. And the third one was the press person, the American press person who collapsed and died immediately. And there was a lot of controversy about him and a lot of Western media attacking that he should have been, should have lived. So we wanted to do a postmortem because the medic arrived at him in seconds because these mobile teams were scattered and there was one station in the media tribune in the stadium. So he was on top of him when he arrested, but he could not be revived. So that was strange for us because he did not recover to resuscitation, immediate resuscitation. So we wanted to do postmortem. They refused. They took him to his country and they did postmortem. And then they found out that he died because of a rupture, massive aortic aneurysm, which of course would not have been possible to revive. And the family have thanked then and apologized for saying bad things about the organization and so on after the event. We had more than 2,400 medical personnel deployed for the event. As you will see, that was by itself a challenge, especially in relations to capacity and training. We had, during the event, we had decided to develop primary care at the front line in all the sites. So whether they are sports or non-sport sites, there were a clinic there to cater so that we reduced the impact on tertiary hospitals from people unnecessary with the, minor illnesses coming to the hospital. And that was extremely successful because the number of people who needed to be seen in the hospital were extremely low. So we had, in addition to these, we had ambulances at all also the sites, and we had also the air ambulance ready for transporting any patient requiring long distance transportation, but we did not needed to utilize it during the event. We also, part of our preparations, we did the major incidents preparedness, a comprehensive response plan supported by the disaster management, WHO disaster management plan. We had a command and control structure that were responsible also for all the healthcare communication by directional communication that manage the entire healthcare services, including the dispatch, the organization of the medical staff, their assignments, and so on. As I mentioned, our service included public health issues, food safety, and these are some of the statistics that you can see. Number of inspections. We license thousands of caterers in a very short time, because these are contracted companies who don't like to bring their caterers long time before the event to reduce the cost on them. So they brought them like maybe 10 days before the event, and we had to do tens of thousands of analysis of them, seeing if they carry any illness, and then certify them. So it was a lot of pressure on our public health. That we were lucky that during the event we did not have any outbreaks, no food poisoning, and no endemic or pandemics at all. Even the COVID-19 was lowest at that time. We had in order to manage these resources, we had a workforce hub that used to control the dispatch of the people in the various stadiums, and have a backup staff to replace if there is need to be replaced. And also that hub used to be a hub also for the ambulance services, because we have located ambulance services in all the venues, but we also have extra ambulances just in case for any reason we need to replace or add ambulances at the sites. The ambulance service have handled more than 6,700 calls during the event. We have a hotline for the callers, and we also had a support by physicians available by phone to call for any person who doesn't want to go to attend a primary care center or a clinic. As I said, we had the lowest incidence of COVID-19. We did so many tests during the event, especially for the workers of the FIFA World Cup. These are some statistics of other things that we've done in respects to blood donations, campaigns, community campaigns. We had language bank, so people, if they don't speak Arabic or English or one of the famous languages, can call that number and get support. I talked about the partnership that we had with the WHO and FIFA about Sport for Health partnership, so I'm not going to repeat that. Ultimately, we had a very, very successful event, and this became a legacy. We were praised officially by FIFA in a letter sent by the director, praising that this set up a benchmark for healthcare services for FIFA World Cup in the future. I hope I can see the second presentation. One of the challenges, of course, can you please put up the second presentation? One of the challenges were, as we had so many challenges before the event, we had issue of capacity. As you know, Qatar has a government healthcare system that responsible for almost 90% of the healthcare system in the country, by about 13 at that time hospitals in the country, and about 25 primary healthcare centers. And the private sector is very small. So capacity was an issue. The resources, as I mentioned, I insisted to use our own. So we had, that was a challenge of how manipulating the resources so that they cover the event, but at the same time not affecting the this is part one. Can we have part two, please? But one of the other challenges is the training of the healthcare resources. We try to find out how the previous World Cups or any sporting event did in terms of training of the resources. Well, we didn't find anything published about training at that time in major event. So, this was for us important because we wanted to go for gold. We wanted to provide the best possible healthcare services, and therefore the medical workforce need to know the know-how and know everything about sporting events. Many of them have not been engaged previously in any sporting events activity. Also, the other challenge is the requirement of the FIFA, especially in relations to the field of play teams at a special certain level of competency and so on, which dictated that we develop our own training for the. So that was quite challenging, especially that you know that these people also work in their normal working hours. So it was difficult to get them out of the from their work to attend training, as well as providing the services that they are supposed to be providing. So what we did is we did the analysis of the requirement, and then we looked at the challenges and put the solutions and written the training plan, thinking of the influx of about 1.5 million visitors requiring the services. So we had to train about 3,500 total medical staff, including doctors, nurses, paramedics, and so on. So what we've decided is to divide the training into online component, which were mandatory 5 to 7 hours of interactive learning per person, and we developed the online training modules, and every person required to be providing services for the event had to complete the online before they were able to go and do the on-site components. And we had 8 days of practical training per team. Each stadium has its own team. And we tried to keep the same team throughout from 2020 onward, because change of the team would create, familiarity with the stadium and so on mandated that we try to keep the team as it is. And therefore, the other challenge was the accessibility of these teams to their own stadiums, because it's limited. Because of certain reasons, they did not allow our healthcare into the stadiums except very late in 2022, beginning of 2022. So we had to then do all the on-site training later before the event. We had also specialized training done to all of them by our state-of-art sports medicine hospital, Aspetar. Things like concussion, cardiac arrest in players, and so on, critical things that could happen to a player that necessitates the intervention of our team. Minor issues usually for a player are taken care by the team doctors, you know, like small injuries or fall, but the life-threatening condition or limb-threatening, they will call for the national service. I spoke about the need assessment that we've done, intensive training carried out, both on-site and physically. And these are a number of modules and topics that have, I'm not going to go through them one by one, but you can see even the code of conduct, for example. We needed that every person would react professionally during the event for any of the guests of the country. We did field of play for the teams on the field. And the part of our training was mass casualty management based on the WHO system. And at the same time, although the event happened during the winter times, but we had days where we anticipated that they're going to be a hot environment and hot temperature. And actually it was, because some of the days the temperature were between 15 and like 27, 29. So during the day it's hot, especially for spectators walking to or out of the stadiums. And we had several cases of people feeling drowsy and falling because of the heat exhaustions and not drinking water. So part of the training was managing heat exhaustion, and we had extensive heat exhaustion training for all our team. I'm not going to go through the details, mass gathering training that developed, modified from the WHO and integrated into our training. So this shows the breakdown of the staff. We had about 1,000 people from Hamad Medical Corporation Emergency Department staff trained, because they are required a specialized emergency, at least one in each of the venues as a requirement. We had 1,000 of primary health care and so on, you know, the other aspects of the training. This training became a standard training for the country. We have Hamad International Training Center. They took up the entire training package, and they made it as a training available for anybody requiring medical training for sport events. So that was part of the legacy of the leaving a training that was done specifically for the event to remain for the any future events in the country. So I think this is the last slide. We handpicked our team and we emphasize that when they are picked, if they are happy to participate, then they would remain the whole entire period. We started picking them in 2020, almost, especially to enroll them in the training, but they must remain with us because of the difficulty of retraining. If we lose a large number of them, of course, the people, if they are leaving or sick or they want to opt to leave the program, they can, but it was reduced to really a minimum. So I think we only lost about one or two persons from the entire period opting to go out of the program because they were not interested. As you see, we try to standardize everything according to a very well-known structure and systems that are available, but modified for the event. Thank you so much.
Thank you, Dr. Abdul Wahab Al-Muslih, for the talk.
Okay. It is my pleasure actually to present Professor James Phillips from USA. He is a chairman disaster medicine section in American College of Emergency Medicine. He is the CEO of Game Day Men Health, Germantown, Maryland, CNN medical advisor during the COVID-19 pandemic. And he is the founder and director of Mass Gathering Disaster and Operational Medical Fellowship. He is the former chief disaster medicine, George Washington University, disaster medicine consultant for so many channels, Netflix, Warner, and also he from USA, Washington, DC. Professor, you can start, please, your presentation. Thank you.
All right, good morning, everybody. Let's see if we can get my slides up there. Is there anything I need to do up here?
Soon it will be there, don't worry.
Okay.
Yes. Yalla, Salam. It's okay. Huh? Okay. Okay, you can start now, please.
Okay. So good morning. My name is James Phillips. It's a pleasure and an honor to be here. I really appreciate the invitation to be able to come all the way here from Washington, D.C. to discuss the United States approach to mass gatherings in general, but in mega sporting events in particular. There's two lectures I'll be giving today. The second one is more relevant to the World Cup and how you here in Saudi Arabia will be planning for that over the next 8 years. But I wanted to touch on a topic that may be relatively unfamiliar to most of you because the United States and the way that our government is set up allows for some not wonderful things sometimes, like protests and riots that can occur. And when hosting a World Cup with thousands and thousands of international visitors, sometimes there's some surprises that happen. And it's important to understand riots, crowd control, and the law enforcement measures that are taken whenever these things occur. So I'm going to give you an American perspective on how we handle civil disturbances and riots, including the law enforcement measures and some of the measures taken by the protesters against law enforcement to give a perspective on how things work in the United States and countries that have protests like ours. Okay, so thank you so much for the wonderful introduction I was given that talked about some of the things I've done in my career. But I also like to talk about my own, what I call my past medical history. I am an emergency medicine physician, board certified in the United States, and I've completed a fellowship in disaster medicine, which some of you probably have also studied in disaster medicine. I studied side by side with several Saudi fellows at Harvard when I was there in Boston. Prior to becoming an emergency physician, I was a plastic and reconstructive surgery resident for 5 years, including a trauma surgery rotation at the University of Michigan. I'm from Oklahoma, born and raised, which is where I attended undergraduate and medical school. And more importantly, here's a picture of my beautiful wife and my 3 children at home, whom I can't wait to get home and see again. Today's learning objectives, we'll talk about a few things, but we're mostly going to review weapons and tactics that are used both by protesters and by the law enforcement agents who are trying to help keep control. I have no particular conflict of interest. So let's dive right in and talk about the different categories of weapons that we see used in protests and civil disturbances when things get violent. So the historically most common thing that we see, just like wars thousands of years ago begin with rocks and sticks, we see the same thing when we have protests. And typically these blunt instruments that you see here are the most commonly seen measures used by police and by protesters against them. There's a wide variety of these. Police in particular use the one on the bottom left, which is, or your bottom right, which is called a nightstick. But we also see these collapsible batons used by police, various other implements like this that are bats and poles and things like that that are used to strike. Not only do protesters use them, but the police use these, and it's part of their training to be able to use them to push crowds back and particular ways to strike people if they must, in a way to cause as little injury as possible. Unfortunately, there are real injuries that happen. Now, I'm going to focus quite a bit on what were the biggest protests in the United States over the last decade. Primarily the ones that made world news were the major protests we saw that are known as the George Floyd protests, which were protests against the government after an unarmed citizen was killed by police. And then on January 6th, which is pretty well known around the United States, when an insurrection happened against our own Capitol building in Washington, D.C., where I was a first responder. You'll see a number of these photographs that demonstrate the blunt instruments that were used on those days. And there were a number of injuries of police and citizens themselves. The sort of ad hoc, the instruments that were used were not necessarily designed for this type of violence. We saw the use of flagpoles, the use of crutches. We saw the interesting use of American flags attached to poles that were used to harm American citizens. It was a very surreal situation. The injuries that occur from these types of blunt injuries are the typical ones that we would see in the emergency departments from all types of blunt trauma, particularly bruising and contusions, head lacerations whenever those blunt instruments strike bony parts. And these typically require laceration repair, but oftentimes imaging of the CNS. Now, one of the things that we noted that was seen a lot on TV during the January 6th protests is that the very measures that we took for crowd control using these, what we call bicycle racks, are set up to make a perimeter. These were actually turned into weapons against law enforcement. I took care of a number of police officers on that day that had shoulder injuries and other orthopedic injuries caused by the use of these bike racks against them. When blunt instruments are not enough for crowd control police to get things under control, we start to see the use of chemical irritants against crowds. Now, chemical irritants have a long history in warfare, particularly starting in World War I, where we would see chemical gases such as chlorine and phosgene that were used to kill people, but even lesser ones that were used to cause irritation of the eyes and the respiratory tract to try to get people to flee. And those less deadly gases are still used worldwide for crowd control. The primary one that we see is known as tear gas, or CS gas in its NATO designation. And we see this a lot on TV when crowds are being asked to disperse by police. And if any of you have ever come in contact with CS gas, you know it's not very pleasant. I've also been trained as a tactical SWAT team doctor, where I go with police on their missions for against high-risk individuals, and oftentimes we'll see the use of these gases. These are primarily irritants against the mucous membranes that cause excessive tearing, blepharospasm, so you can't open your eyes, very severe coughing, and give you a strong desire to get out of that area to fresh air. Now, fortunately, these symptoms typically resolve in 10 to 30 minutes without the need for any medical treatment or antidotes. We see the widespread use of these chemical irritants in the United States and around the world to help disperse crowds. Of course, we can see them used here even in front of the White House itself on days when protests are becoming particularly lively. Now, how do these chemical irritants work? Well, I'm from the southern part of the United States where we really like our spicy food. We really like different types of peppers. And each different type of pepper around the world has a different amount of capsaicin in it. And capsaicin is that chemical compound that is concentrated into these gases. So if you've ever cut a pepper and accidentally wiped your face or wiped your eye before you washed your hands, you understand a small amount of how painful that can be. And so the Scoville scale is a measurement of how hot the pepper can actually get. And when you move all the way up to the top of these peppers, where you're getting into the ghost peppers and something called pepper X, things get pretty serious, and that can actually cause gastrointestinal distress whenever you eat them. Now, how are pepper sprays and CS gas and these other chemical irritants dispersed? Well, in a number of ways. We'll typically see them used on the bottom here. You'll see what we call smoke grenades or smoke canisters, where it's like a grenade where a pin is pulled and then it's thrown into the crowd. There's also mechanisms where they can launch these with a type of firearm. And you can even use a paintball gun, where instead of using paint pellets, they're using pepper balls to disperse the crowd. Pepper sprays also come in the form where you can use them yourself for personal protection. You can carry your own small canister of pepper spray if you're being attacked. Now, in more recent times, particularly on January 6th, we became familiar with a much more concentrated and a much more widely dispersed version of these personal canisters, something that has been colloquially known as bear spray. Because in the United States, where we have these large mammals that can attack you, such as grizzly bears and black bears, if you're out in the woods, you can carry one of these large canisters of pepper spray that shoot from here to that fourth row out there, and you can spray this large mist to try to keep the bear from attacking you. Well, on January 6th, we started to see protesters and those that stormed the Capitol building using these sprays as weapons against law enforcement themselves. And it's very difficult to protect yourself. When you get these sprays directly into your face, your mouth, your eyes, it will incapacitate you. And I took care of dozens of police officers that day to help flush their eyes, wash their skin, and try to alleviate the symptoms. What we know is when you eat capsaicin, or when you get capsaicin in your eyes or mouth, strangely enough, milk, cow's milk, goat milk, whichever it is, but cow's milk is most common in the United States, actually helps to absorb those chemicals and help alleviate the symptoms faster than water. You'll find that our organized protests in the United States often will provide instructions to the protesters ahead of time on how to manage them in anticipation that law enforcement is going to use these chemicals against them. Like I said, from the beginning of time, we've used sticks and we've used rocks to hurt each other. So thrown projectiles take on a number of different forms, and we see them in protests around the world. It's not uncommon to see things as simple as a can of soda, a rock, pieces of brick that are found on the ground. Batteries, for some reason, became a particular weapon in Washington, D.C. that day because they're very dense and can be thrown a very far distance. And even if they're small, if that hits you in the head, it can cause a laceration or an eye injury. That's why you'll typically see riot police and even protesters wearing helmets. In the picture on your bottom left is from South America, where protesters were actually making these thrown projectiles made of human waste, feces and urine, which are basically biological weapons that they were throwing at law enforcement agents. Famously here at January 6th, there was a video of someone using a fire extinguisher and launching that against a law enforcement officer who ultimately died from the protests that day. Now, in addition to the chemical gases that we talked about, there's also thrown projectiles that we call disorientation devices. Now, military forces and law enforcement forces will use these distraction devices that are typically a very loud bang and a very bright flash. We call them flashbangs. And if one of those is thrown into a room before a police or a military team goes inside, anybody in that room will have a very loud concussive force in their ears that will very much limit your hearing, and a bright flash that even with your eyes closed will still cause some loss of vision temporarily, as if you were looking into the flash of a camera. These are used against crowds and protests. And you can see some photos here from January 6th and otherwise, when they were even thrown close to the media, and you can see the outcomes of those disorientation devices. Now, some of those devices, like the one you see at the bottom there, will actually launch out small, hard rubber balls called sting balls. And these sting grenades do cause injury. It's important to note that these different law enforcement weapons that are used against crowds are not non-lethal. They do cause injuries and deaths, but we call them less lethal weapons now. And what we can see is the effects of some of these less lethal weapons are still serious. These sting balls, if they are thrown and explode near you, can cause the simple contusions and lacerations that you see on one side, but even penetrating trauma, they can be quite disfiguring. And you can all imagine what this would do if one of those balls hit you in the eye. And these types of kinetic impact projectiles are also used in lieu of using actual metal bullets against protesters. In the United States, it is illegal to use firearms against a crowd, as it is in almost every country in the world. But less lethal projectiles are used against crowds when things get really severe. They're typically known as rubber bullets, even though they're made from either plastic, rubber, or even bean bags, which is a small fabric container filled with typically beans or some sort of other hard beads that are not designed to penetrate through the skin, but do cause severe pain and can even cause fractures and other serious injuries. And these come in a variety of different types. And you can see these very large baton rounds up high. And if one of those was to hit you in the head, the neck, or the eyes, would cause very serious injuries. Law enforcement agencies are trained to aim these below the neck, but accidents and malicious characters do happen. So sometimes these injuries serious injuries can occur. And as emergency physicians and those who take care of people with acute trauma, it's important to understand the different patterns of injury that you see from these projectiles. Bean bags and these other types of projectiles are actually used in real firearms. So you can see that these bean bag rounds here are a 12 gauge round that fits into an actual shotgun that would normally be used for hunting in the United States. So these can cause real serious injuries if they're used improperly. And some of the patients that we've seen have had not only injuries to the trachea, sinus injuries to the frontal sinus, severe injuries to the mouth. And in the CT scan there, you can see that these bean bags, if they rupture, the inside, the small hard objects inside those can actually penetrate into the body, such as these small metal objects did in this person's face. Incendiaries are also seen worldwide. And they're used against police officers and against governments as a form of protest, and they have been for nearly 100 years. Now, in particular, we see Molotov cocktails, as they're known. Mr. Molotov was the Soviet Minister of Foreign Affairs at the beginning of World War II. And when the World War II progressed and the Nazis and the Russians were fighting, we started seeing the use of bottles filled with gasoline and other accelerants with a rag placed inside of it. You light that on fire and throw it, and when the bottle breaks, the gasoline disperses and sets everything on fire. It's used in arson around the world, and it's used against police officers. On January 6th, in the United States, we had a near-miss event where this ice chest, this cooler, was filled with these Molotov cocktails that were ready to be used against the police at the Capitol that year. It's important whenever law enforcement responds to large protests like this, that they bring fire extinguishers and have ready the implements to be able to put out fires caused by these accelerants on people. Now, One of the more concerning developments over the last few years is the use of commercial and private fireworks against law enforcement by crowds. Now, fireworks are wonderful. We love them. We celebrate them with them around the world. In the United States, we love using fireworks on the 4th of July, which is the celebration of our Independence Day from Britain. And unfortunately, those fireworks, which in most states are available for private purchase and use at home, they contain black powder and gunpowder that, if used as a weapon, can cause serious harm and destruction. We even saw them used against law enforcement, causing serious injury. Now, fireworks can range from very small firecrackers and small things that don't cause much harm, all the way up to those large mortars that shoot way up in the air and explode. Those are very similar to weapons that are used in war and have been launched and used against our law enforcement officers. Bladed weapons do happen. We do see stabbings and lacerations at protests. In particular, on January 6th, if you watched the news, you saw this individual who was a very strange man, who was one of the protesters that entered into the Capitol building. And I actually, when I was there on January 6th, saw a number of these American flags with a blade attached to the tip of it. And I can't begin to tell you how that makes me feel without getting upset, but to see such a weapon used against our own people was very disturbing. Vice versa, whenever protests happen in the United States, there's often counter protests. Two groups of people can have opposing protests, and oftentimes those can turn violent. And in particular, there were 4 people stabbed between these two violent protests group in Washington just a few years ago. Conducted energy weapons are also something that we have used in the United States and around the world for a long time, typically known as tasers, which is a non-lethal weapon used to try to subdue someone who's being suspected of a criminal act. However, they're also commercially available in the United States. If I wanted to go in most states and purchase a taser for my own personal protection, I could do that. So if I were being attacked by someone, instead of shooting them with a gun, you can use one of these less lethal forms of protection against them. And just like with bear spray, we actually have different forms of this that are used to help protect you from wildlife if you're out in the woods and you come across a bear or some other animal that tries to attack you. A typical taser is the one you see here, where you make physical contact with them to deliver a high voltage shock and temporarily incapacitate them. The police also use a version of this, which is the taser, which shoots out 2 electrodes on these barbs that will stick into your skin, and then they push the button and they can shoot you with that electricity from a distance where they're safe. We see those patients later come into our own emergency departments where the physicians have to remove those barbs from their skin before they go to jail. And the walking stick you see here, which is just something that someone would use to help them go hiking over rocks or through the forest, is actually an implement that has an electric charge inside of it. This individual that stormed into the Capitol building in the United States on January 6th and is sitting in the office of the Speaker of the House, the highest office in our US Congress, putting his feet up on her desk, is actually carrying one of these hiking weapons that he hoped to use against Congress and against law enforcement when there. Now, as much as we don't like it, firearms are a real reality in our country. Firearms have been used in protests for 100 years, 200 years in America. As I said before, the government is not authorized to use firearms against crowds, but there have been incidents in the past during large protests when the government has opened fire on crowds, killing people. In particular, an event that happened during the Vietnam War protests of the 1960s and 70s on a university campus, when our own National Guard showed up and started shooting students. Now, do we have to worry about firearms in the United States now? Well, we have all these laws that you shouldn't be able to bring firearms, and different states get to make their own laws. In Washington, D.C., until recently, it wasn't legal to carry a firearm. Politics have changed in the United States, And there's more and more and more firearms being allowed into Washington, D.C., like there are in other states. While people deny that firearms were present at January 6th, I can tell you that there were a number of firearms that were there. And we have seen protests around the United States where it's actually legal to show up at a Capitol building with these firearms. It's just the state of affairs in the United States that we deal with today. And I fear the day when firearms are used widespread in large protests. Now, as we advance technology, lasers have become weapons, and that seems like science fiction in the future. But fortunately, we're not quite at the point yet where lasers are significantly powerful enough to just be used to shoot a person directly and hurt them. But where we typically see lasers cause harm is with the eyes. And it can cause a range of injuries to your eyes. It can cause simple distraction and temporary blinding, which, believe it or not, has become an issue with airplane pilots and helicopter pilots when trying to land their airplanes. There's been several incidents in the United States and many in Europe where, as a plane is coming to land at an airport, someone will be on the ground and see them and try to shine a laser at the cockpit of the airplane to try to distract the pilot. Fortunately, that hasn't resulted in any airplane incidents yet, but we are mindful of that possibility. Here you can see in regular protests that these green lasers, which are available to anybody to be used as a laser pointer during lectures like this, can be used to try to blind people. The red lasers that we typically see here, typically used in presentations, are of a wavelength that don't cause damage to your eyes unless there's really purposeful, sustained contact with your retina. But green lasers are more powerful, and you can see that, and these pictures are not from the United States, but you can see that protesters have adapted these as weapons to try to actually use against law enforcement officers who are there just trying to do their own job. Temporary blindness can occur, and we don't typically see long-term retinal damage from lasers. However, as different lasers become more commercially available, particularly the blue wavelength of lasers, we are seeing that that particular amount of energy can cause retinal damage that is permanent. Just like staring at the sun can cause some permanent retinal damage, these higher frequency lasers can do the same thing. In fact, they have enough energy in them now that they can pop a balloon from across a room. And so there are limits that are being placed on the commercial availability of some of these lasers, but we should be mindful that these are becoming ubiquitous across the world and can be used in protests. So improvised explosive devices. The whole world is familiar with IEDs. So what is an IED? Well, quite simply, an IED is the use of materials in a way that they were not designed to be used to cause an explosion, to cause damage or injury to property or people. Prior to January 6th, on January 5th, 2 IEDs, 2 bombs were found at the headquarters of the Republican Party and the Democratic Party in Washington, D.C. These are what we call pipe bombs. Fortunately, they weren't detonated, and to this day, we're still not sure who placed them. But what we know about pipe bombs and what we know about pressure cooker bombs, which is just a big pipe bomb, is that those who want to wish harm on people can take gunpowder from fireworks, empty that out, and then store it inside of a much more powerful container that has higher structural integrity. Place a fuse in it, and then detonate it. And there's many different ways to detonate these devices, whether that's just by lighting a fuse, using a timer, or detonating them using a cellular phone. These are pipe bombs that you see here, which are typically metal, typically lead pipes that encase this explosive material. And it's the type of material that if you just had gunpowder sitting out here and you light it on fire, it simply burns in a fire. But once you contain it inside of something like this, the pressure will build until the structural integrity of that container will be lost and then explode, shooting out fragmentation and shrapnel at the surroundings. I'm sure everyone is familiar of what happened in the United States at the Boston Marathon bombing. I was in Boston at the time, and I was a doctor at the finish line tent every year except that one year. But I was living in Boston doing my disaster medicine fellowship at the time of the Boston Marathon bombing. In fact, both of the bombers came to my emergency department when they were injured and killed themselves. This is a diagram of a pressure cooker bomb that demonstrates how explosive material is placed inside of one of these pressure cookers and then surrounded by metal objects like nails or nuts or ball bearings that are then projected out just like a bullet and can cause serious damage and death. The types of injuries that we see are wartime injuries. We see severe facial trauma. We see penetrating injuries to the skull. If you are unfortunate enough to have one of these go off in your hand, you can see the amount of damage that occurs. And the pictures on the left are actually from wartime, where an Iraqi child and a US soldier are here showing the injuries that occurred from shrapnel from pressure cooker bombs. Both survived. Now, in recent years in the United States and really around the world, we've seen a very concerning trend. We've seen terrorist organizations around the world promote the use of vehicles as weapons. That's come from both ISIS and from Al-Qaeda in their formal documentation, their formal newsletters that they mail around the world by the internet to teach people how to use vehicles as weapons. Around the time of 2014 through 2017, we started to see a very large increase in the use of large trucks, transportation vehicles, and even simple automobiles being driven into crowds to cause death and injury. Prior to a few years ago, there was not really a great term that we used to describe these attacks. They're called vehicle attacks or ramming attacks, but it doesn't define really what it is. My research team, we call these tarmac attacks. Tarmac is an English word that means the same thing as pavement or concrete. We also know the use of tarmac when it comes to airports, which is where the airplanes sit. So using that as an acronym, we now call these tarmac attacks because they're targeted automobile ramming mass casualty attacks. And why are they important? Well, they're important because this is unlike any type of traumatic mass trauma that we've seen ever in the world. Typical mass trauma, we think of explosions and mass shootings, chemical and biological attacks, but now we're starting to see mass blunt trauma. And no matter how your emergency departments might prepare, no one is prepared for this specific type of mass trauma. This is a particular picture from a protest and counter-protest from 2017 in my current home state of Virginia. This was a college campus where a march was allowed to occur promoting basically white supremacy and Nazi beliefs. And so, of course, a large number of people showed up to counter-protest that. Well, one of those individuals decided to accelerate his sports car into that crowd of individuals, and this is a photo from that time. I developed a research team that spent a lot of time researching the actual injuries that came from that particular tarmac attack. We published it in a number of places, and when you hear from my colleague, Dr. Mayno, in a short time, one of Dr. Mayno's co-authors on his book, Bill Brady and I, we co-authored these publications together, along with my team at GW, where we took a look at the types of blunt trauma we see that were particularly lower extremity orthopedic injuries, but also injuries as severe as the one death that occurred was an aortic dissection in the field. And despite a thoracotomy in the emergency department, she still perished. But we also saw a number of other interesting injuries. We saw vascular injuries that required interventional radiology. We had 3 operating rooms happening at the same time that all required orthopedic surgeons. And so general surgeons may not be as useful as orthopedic and vascular surgeons when a tarmac attack occurs. During the George Floyd protests over the last 5 years in America, we saw hundreds of instances where these vehicles have been used against crowds. And the largest of these types of events happened in places like Nice, France, where hundreds of people were killed and 800 or more people had injuries. Now imagine that type of trauma happening in your country just from the use of a commercial vehicle being driven into a crowd. And imagine how your emergency departments would have to respond to so many different injuries. So anytime a new type of attack modality is invented, we have to figure out ways on how to combat that. So anti-tarmac technologies exist. And you may not even recognize whenever you see these. You see these poles, what we call bollards, that are usually found around government buildings throughout the world. And you think of them as flower pots or planters, like these concrete ones you see here that have plants growing in them. They serve a purpose. They're not there for decoration. They're there to keep vehicles from driving up next to them and detonating a bomb. They're also used to be able to protect people on the sidewalks from being hit by these vehicles. Outside of the Capitol building here, you can see these sort of decorative bollards that aren't very distracting, but they do prevent vehicles from being able to come that way. Now, there are temporary measures as well. You see when you drive into an embassy or you drive into other government buildings that some of these bollards can actually sink into the ground and be hidden and then brought up out of the ground when necessary. There's also new technologies. Is it time? Okay. There's also new technologies that have been developed where you can temporarily place anti-tarmac technologies to prevent vehicles from being driven in, whether those are spikes that cause flat tires or just general disruption of the flow. In Washington, DC, these are photos that I took before some of our events where we just put big trucks in the roads to prevent the possibility of people getting through. I'm being told I only have a couple of minutes, so I will hurry along through what we need to worry about for the future and when you're hosting mass gatherings in your country. Directed energy devices are coming. These are microwave emitters that are used against crowds to help disperse them. They cause burning of this, a burning sensation in the skin, but no actual damage. And these can shoot microwave radiation out across a long distance to help disperse crowds. We do not use these in the United States, but we have used them overseas in conflict areas. We also use technology called an LRAD, which was that last sign that you saw, which is very high volume acoustic sound that is blasted at your ears, which doesn't cause permanent damage, but will cause you to disperse. And then my biggest fear, and what should be everybody's fear, is the use of drone technology in protests. And I don't mean surveillance against crowds. That's being used in the United States now. But drones, as you've seen what's happening in Russia and Ukraine right now, are being used as explosive devices against crowds. And that's going to be something that we have to worry about in the future. And anti-drone technology will continue to evolve to catch drones, interfere with their communication ability, or knock them directly out of the air. These are some references if people are interested in knowing what I used to put this lecture together. And this is me at the Capitol building on January 6th, which was a very dark day for our country. I thank you for your attention, and I'm available for any questions.
Thank you very much, Prof. Phillips, for the nice talk. We will delay the question session after the opening of the ceremony. Thank you so much.
السلام الملكي.
السلام الملكي.
أهلاً وسهلاً بكم جميعاً في المؤتمر العالمي الثالث لطب الحشود والطوارئ تحت رعاية كريمة من صاحب السمو الملكي الأمير سلمان بن سلطان بن عبد العزيز آل سعود أمير منطقة المدينة المنورة. إنه لشرف عظيم أن نجتمع اليوم لنناقش أهم القضايا المتعلقة بطب الحشود والطوارئ ونسعى معاً لتحقيق الأهداف السامية التي تعود بالنفع على المجتمع، وخير ما نبدأ به هو القرآن الكريم. إن طب الحشود يمثل تحدياً كبيراً في ظل الظروف الطارئة، حيث يتطلب العمل الجماعي والتنسيق بين جميع الجهات المعنية. هذا المجال يسهم بشكل مباشر في إنقاذ الأرواح وتقديم الرعاية اللازمة في أوقات الأزمات. والآن ندعو رئيس اللجنة المنظمة الدكتور محمد الفيفي لإلقاء كلمته.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء وسيد المرسلين سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. سعادة الدكتور سامي الرحيلي، مدير عام فرع وزارة الصحة بالمدينة المنورة، الأخوة والأخوات الحضور، برعاية كريمة من صاحب السمو الملكي الأمير سلمان بن سلطان بن عبد العزيز أمير منطقة المدينة المنورة، يسرني أن أرحب بكم جميعاً في المؤتمر العالمي الثالث لطب الطوارئ وطب الحشود 2025 في المدينة المنورة في طيبة الطيبة. يجتمع في هذا المؤتمر نخبة من الخبراء والمتخصصين من داخل المملكة وخارجها لمناقشة أحدث الممارسات الصحية وتبادل الخبرات العالمية في إدارة التجمعات البشرية، بما يعزز جاهزية الأنظمة الصحية ويرسخ مكانة المملكة الرائدة في مجال طب الحشود والطوارئ انسجاماً مع تطلعات المملكة لرؤية 2030. ويطيب لي أن أوجه ترحيباً خاصاً بالزملاء المتميزين بالحضور من الولايات المتحدة الأمريكية وماليزيا وقطر الشقيقة، والذين يضيف حضورهم قيمة علمية ومعرفية كبيرة لهذا الحدث الكبير. كما يسعدنا أن نعلن أن المؤتمر قد تم اعتماده من الهيئة السعودية للتخصصات الصحية بواقع 20 ساعة تعليمية، مما يتيح للممارسين الصحيين الاستفادة من محتواه العلمي المتميز. Dear guest, under the gracious patronage of His Excellency Royal Prince Salman bin Sultan, Governor of Al Madinah Al Munawwara region, it is my great honor and pleasure to welcome you all to the 3rd International Conference on Mass Gathering and Emergency Medicine 2025. Here in Al Madinah Al Munawwara, holy city of Al Madinah Al Munawwara. The conference brings together distinguished experts and professionals from the kingdom and across the globe to share the best practices, exchange knowledge and expertise for health challenges associated with the large-scale gathering, in alignment with the aspiration of Saudi Vision 2030. I'm especially delighted to extend a warm welcome to our esteemed speakers from the United States, Malaysia, and Qatar, whose participation greatly enriched our conference. We are also pleased to announce that the conference has been accredited by the Saudi Commission for Health Specialties for 20 CME hours, providing participant and student with an outstanding educational opportunity. Thank you very much.
نصل الآن إلى لحظة التكريم، فليتفضل مشكوراً سعادة الدكتور سامي الرحيلي مدير عام فرع وزارة الصحة بالمدينة المنورة، وسعادة المهندس عبد الله أبو النصر رئيس مجلس إدارة شركة رؤية المستقبل للتدريب الصحي لتكريم المتحدثين والمشاركين. تكريم اللجنة المنظمة ويستلمها الدكتور محمد الفيفي رئيس اللجنة المنظمة، رئيس جمعية طب طوارئ الأطفال، استشاري طب الأطفال والطوارئ، أستاذ مشارك في كلية الطب بجامعة الفيصل الرياض. دكتور جيمس فيليبس رئيس قسم طب الكوارث، الكلية الأمريكية لأطباء الطوارئ، الرئيس التنفيذي مركز جيم داي صحة الرجل جيرمان تاون، محلل طبي في شبكة CNN أثناء جائحة كوفيد 19، المؤسس والمدير زمالة عملية الكوارث وطب الكوارث، الرئيس السابق قسم طب الكوارث جامعة جورج واشنطن، استشاري طب الكوارث واشنطن الولايات المتحدة الأمريكية. دكتور جون كارتون مينو، المدير الطبي حلبة ميشيغان الدولية للسباق بروكلين، ميشيغان، المدير الطبي ورئيس خدمات الطوارئ الصحية مقاطعة جاكسون ميشيغان، مؤلف إدارة طب الحشود، دليل الإدارة الطبية للأحداث الكبرى، أستاذ مشارك قسم طب الطوارئ جامعة ولايات ميشيغان جاكسون ميشيغان الولايات المتحدة الأمريكية. البروفيسور أبو حسن عبد الله، المؤسس والرئيس السابق لقسم طب الطوارئ وخدمات الإصابات ماليزيا، رئيس مجلس طب الطوارئ أكاديمية الطب الماليزية، عضو المجلس الطبي الماليزي، رئيس لجنة لوائح وأدلة الممارسة في الطب التجديدي وزراعة الخلايا الجذعية والعلاج الخلوي، استشاري زائر قسم الطوارئ مستشفى كوالالمبور وزارة الصحة الماليزية. دكتور عبد الوهاب المصلح، مستشار مشروع المدير الطبي في مؤسسة حمد الطبية الدوحة قطر، عضو مجلس إدارة الوكالة الوطنية لمكافحة المنشطات قطر، عضو لجنة مكافحة المنشطات التابعة للمجلس الأولمبي الآسيوي الدوحة قطر. البروفيسور سعيد الغامدي، استشاري جراحة الأوعية الدموية، نائب المدير التنفيذي للتدريب التجمع الصحي الأول بالرياض القطاع الخامس، الرئيس السابق للجنة الفنية الإشرافية للمستشفيات والمراكز الأولية في المشاعر المقدسة الرياض. البروفيسور بدر الغامدي، استشاري الطب الباطني وطب الجهاز التنفسي، حاصل على البورد الأمريكي والزمالة الكندية، أستاذ ورئيس قسم الطب سابقاً كلية الطب جامعة الملك خالد، الرئيس التنفيذي شركة تداوي الطبية أبها. دكتور مؤيد البدراني، أستاذ مشارك واستشاري الصحة العامة وطب المجتمع، قسم طب الأسرة والمجتمع والتعليم الطبي، كلية الطب جامعة طيبة المدينة المنورة. دكتور عبد الله الهوساوي، رئيس قسم المعلومات والخدمات العلمية، معهد خادم الحرمين الشريفين لأبحاث الحج والعمرة، رئيس مركز أبحاث الحشود وإدارة الحشود جامعة أم القرى مكة المكرمة.
الدكتور السري عسيري، لو سمحت تتفضل المنصة. دكتور سري عسيري، مدير القطاع الغربي لهيئة وقاية، هيئة الصحة العامة. تفضل يا دكتور.
دكتور مازن الشمراني، أستاذ مشارك هندسة الحاسب والتقنيات المتقدمة، معهد خادم الحرمين الشريفين لأبحاث الحج والعمرة، جامعة أم القرى، مكة المكرمة. دكتور عبد الرحمن بشاوري، مشرف وحدة أبحاث السلامة والطوارئ والكوارث، استشاري إدارة الحشود لشركات الحج، معهد خادم الحرمين الشريفين لأبحاث الحج والعمرة، جامعة أم القرى، مكة المكرمة. دكتور عبد الرحمن الجعيد، استشاري طب الطوارئ، زمالة طب الطوارئ، جامعة أوتوا، كندا، أستاذ مساعد، كلية الطب، جامعة طيبة، المدينة المنورة. دكتور أحمد الغبان، أستاذ مساعد واستشاري طب الطوارئ، خدمات طب الكوارث والطوارئ، قسم الطب الباطني، كلية الطب، جامعة طيبة، المدينة المنورة. دكتور عاصم الحجيلي، أستاذ مساعد في التمريض، جامعة طيبة، رئيس قسم تمريض الأمومة وصحة الطفل، زميل مشارك أكاديمية التعليم العالي البريطانية، المدينة المنورة. دكتور خالد غليلة، استشاري الأمراض المعدية للبالغين، رئيس قسم الأمراض المعدية، مدينة الملك سلمان الطبية، المدينة المنورة. دكتور عبد العزيز عسيلان، استشاري الأمراض المعدية، نائب رئيس لجنة ترشيد المضادات الحيوية، مدينة الملك سلمان الطبية، رئيس اللجنة العلمية، النادي الإقليمي للأمراض المعدية، المدينة المنورة. دكتور تسنيم الفريدي، استشارية طب الطوارئ، متخصصة في طب الكوارث والطوارئ، المدير الطبي، هيئة الهلال الأحمر السعودي، المدينة المنورة. دكتور محمد إسماعيل، عضو الكلية الملكية للجراحين، إدنبرا، في الرعاية قبل المستشفى، مدرب دولي معتمد، ومدير سابق خدمات الإسعاف الجوي، المدينة المنورة. دكتور مصطفى غوتا، أخصائي الخدمات الطبية الطارئة، هيئة الهلال الأحمر السعودي، ذو خبرة في العناية المركزة، ومهتم بالأبحاث التطوعية والتدريس بالمدينة المنورة. والآن يتشرف رئيس اللجنة المنظمة وسعادة رئيس مجلس إدارة شركة رؤية المستقبل للتدريب تكريم سعادة الدكتور سامي الرحيلي، مدير عام فرع وزارة الصحة بالمدينة المنورة. نشكر جميع المتحدثين والمشاركين على جهودهم القيمة، ونتمنى لكم مؤتمراً مثمراً وناجحاً.
الآن بإمكاننا أن نستمتع بالكوفي بريك إن شاء الله، وبعد نص ساعة نرجع. شكرا للجميع وشكرا للحضور. Professor John Carton Meno. He is the medical director, Michigan International Speedway, Brooklyn, Michigan. He is the medical director and chair and chief medical director and chief medical examiner. Jackson County, Michigan, author of Mass Gathering Textbook, a guide to the medical management of large event textbook. Cambridge University Press 2024. Former associate clinical professor of emergency medicine, Michigan State University, Jackson, Michigan, USA. Professor Meno will talk about lessons learned from events at Michigan International Speedway, spectator sport, and concert. Prof, you can start, please. What is it? This one. Okay. So just wait until it comes on the screen. It will be there on the screen. Just give them. Okay. Can start.
Okay. Good morning, everyone. As mentioned, I'm from Michigan International Speedway. I have worked the Speedway since 1984 to the present time. And one of the things that my title says lessons learned. When we learn something, what we do is incorporate in the way we function right away out at Michigan International Speedway. The only disclosure that I have is that I'm one of the editors for the Mass Gathering Medicine and Medical Guide to Large Events that is published by Cambridge University Press out of London. And one of the things that I have done has been, over my career, I have staffed at least 80 races and 10 concerts for the experience that I've had. This is a picture of Michigan International Speedway, it was built in 1968. It's an oval track. It has high degrees. I've worked with every racing organization except for Formula One. The property that we cover is 1,400 acres, and at the track, we have 8,000 campsites, and on race weekend, we're the second largest city in the state of Michigan. This is a map of the track and the area campgrounds that we cover. We provide emergency medical care and EMS for all of those areas. In 1980, Penske Motorsports bought, Cleveland, NASCAR, Nazareth, Rockingham, and the California speedways. Those were also speedways that we've worked at. And then eventually in 2000, NASCAR International Speedway purchased the track, and then NASCAR. And now we've worked with NASCAR for the track. At the track, we have two country western music festivals that are 3 days. It's a live-in campsite. There are 40 to 45,000 attendees. And then at a NASCAR race, we take care of 56 to 137,000 spectators on race weekend. This is another picture of the grounds in the Speedway, and where you see the yellow starred area, that is where we have the concert located there. This is the book that was initially sponsored by ASAP and then published by Cambridge University Press. Two of the doctors on here, Doctors Mark Socher and Christopher Kroll, were physicians that worked for me out at the track, and then they went to different universities, and with their residents, they petitioned the American College of Emergency Medicine to formulate the event medicine section. And then this is just the number of various sections in the American College of Emergency Medicine. And you can see where event medicine overlaps with every single one of these. And with the American College of Emergency Physicians, we recruit emergency physicians, any other physicians that are interested in emergency medicine, and then our mid-levels, which are physician assistants and nurse practitioners. It's a multidiscipline society, and our approach to mass gatherings is a team approach. At Michigan International Speedway, what ended up happening is that we're actually out in the country. And so we have considered it to be setting up a transient city. So as doing this outside, even on the grounds, you have to have everything that you would have to provide care for people in the city. We have fire protection, EMS, law enforcement, security, and then public health that takes care of water, food, waste disposal, and then our medical and public health. We have respite centers that we set up for heat exhaustion, especially during our concerts, and also our intoxicated patients. We have, everyone defines a mass gathering differently. You will see that there are multiple definitions. The real big issue is, if you have a mass gathering of people, is it going to be an indoor event? Is it going to be an outdoor event? Because your approach to it is totally, completely different. And then today, we have stadiums that have roofs over them. So is it a hybrid? Is it a combination of that? And everybody defines it differently. And the reality is that in mass gathering, it's variable as to the number of people and the density. So you have to be able to adapt to the scale. Is it a local fair that only has like 1,000 participants? Or is it a big festival or concert in which you have 25,000 or more? These are all mass gathering events that need to be addressed. The spectator or the person that's attending the gathering, they're really the most important person there. And they have expectations. They want to be comfortable. They want to be safe and secure. They want to have fun and enjoy it. Okay, most mass gatherings are entertaining, and they want to have freedom to express themselves. But the big thing is that no matter what event or what activity you participate in, people get sick or have medical problems. So they expect medical care to be provided for them. The primary purpose that we function on out at the Speedway is that we provide isolated expected medical care that the spectator or patient would expect. The second primary or the secondary purpose is that, we provide immediate care in case there's a mass casualty or disaster that occurs. And then ultimately, I've been doing this since 1984, and having been the medical director of an emergency department, the emergency departments in the United States function at near disaster every single day in that capacity. You really can't get into the medical system unless you go through the emergency department. So we need to provide medical services outside of these events to decompress the local emergency departments. And we need to be able to treat the patients at those events so that they can continue to enjoy the event and participate. As noted, the entertainment venues, these are just examples of it, but then the other ones are going to be political rallies and riots, as noted by Dr. Phillips. And then, as previously noted, the religious pilgrimages such as the Hajj. Those are all mass gathering events. And then concerts, and then professional conferences such as ASEP, such as this one, and then religious events also. The other thing is that with mass gatherings, since most of them are entertainment, many of them are associated with sports. This is just an example from 1993 to 1994, just that there were over 165 million participants just for football in the United States, in the professional sports there. So it's also a big business, and it has become commercialized, around the world. The goals of on-site care is, you want to do triage, evaluation, treatment on-site, and then as necessary, transfer to the definitive care, and then in a lot of my talks, you'll hear decompress the local emergency departments, keep people out of the hospital as much as possible. The targeted groups of people are spectators, okay? And what people don't forget are the performers and the special populations that attend these. Dignitaries, I call it show business medicine. Because the spectators are the very important people. The athletes and the participants are the performers. And we, as the staff that provide care, law enforcement, EMS, you're behind the scenes supporters and the staff. But they also get sick and ill, and we need to provide care for them. So do we provide comprehensive care at these events? Everybody has a definition and knows what a disaster is. And then mass casualties are where you have so many people that are injured that overwhelm your system at the time. The design of the mass gathering event, or when we first started to look at this, we had to come up with, are we just going to be a first aid station, and are we going to transport people, or are we going to take care of them there? Are you going to provide basic life support, which is primarily first aid? Are you going to do treatment and transportation? And are you going to provide ALS services? And are you going to treat comprehensive? Our system is a comprehensive system. I call it a limited freestanding emergency department in which we stabilize and take care of all the emergencies and then transport as necessary. We have had deaths at the Speedway, which I'll talk about later. The other thing is that with such a large event, and since we're the second largest city during NASCAR race weekend, you have to integrate with the local medical communities. But at the same time, you have to have mutual aid, which exceeds and goes outside your county or your small geographical area. When bioterrorism became a common event or thought of in the United States, many of the counties in Michigan kind of regionalized into a mutual aid. Our casualty disaster plan that we set up for the number of counties in District 1 is a tiered response involving all of the hospitals. We have a local response, and then we have the mutual aid, which we share resources. What happens with at Michigan is that we involve multiple EMS agencies from three different agencies, 3 different counties, and we also have multiple hospitals that we use. And then we use a regional hospital, which is out of our district, and specialties such as the University of Michigan. We use the Burn Center. We use Henry Ford Jackson and Sparrow for our burn surge, because with racing, there's always the risk of fire and explosives. And then there's exposure to carbon monoxide. So we also use hyperbaric, which is in Toledo, Ohio, setup. The helicopter service, having been a flight physician, participating in that, they have limited abilities, and they are primarily used as an air medical transport and ambulance service. We're out in the country with our event, so we have large distances for transporting patients. So we use a helicopter service, and we primarily use survival flight out of the University of Michigan. These are just examples of the hospitals that we use and their distances from the track. And you can see that those are relatively long distances. So the helicopter comes in helping. We've used the helicopters for cardiac arrests and resuscitations, and we've also used it primarily for stroke victims that we've had at the track. Our medical plan is that we provide advanced life support within 3 to 5 minutes. We have a large network of the basic first responders and medical first responders trained for. We use the ushers, our fire, security, and we even have used bystanders. The biggest thing that we have found out at the Speedway with major events is that you have to have a robust communication system, because everybody has to be able to be talking to one another. And then we have a surveillance system in which we patrol and identify issues that occur in the parking areas, and especially when the event is over and people are leaving the track. As I said, one of the things that we have developed is a dedicated emergency control and operations center called the EOC. Every call for any assistance goes through the EOC. We have had people use their phones and call in fake events, and then we've had different people, different groups responding to them, which creates chaos. So now what we do is have all calls go through the EOC. And these are the publication, the communication. These are all the people that are participate in the EOC, and they actually have a seat or representative in the EOC. So a call comes into the EOC, it's distributed throughout the EOC, and then they send the information out to their necessary group that they're working with. One of the things that we have found is that the EOC and dispatch makes or breaks the system and how well we succeed with it. But the dispatchers and the people that are working in these EOCs, they have to have knowledge of the institution, the track, but also the counties and also what is available through the state. In case we have a disaster or mass casualty event, because we're going to call in for those extra services. You have internal and external response and coordination. Again, these are the list of everybody that we have to coordinate with it. within our system. We have to have in the EOC redundant capabilities in our primary and secondary communications. Everybody has two channels. Originally, we were using VHF, then UHF, and now in the United States, we use 800 megahertz. We have multiple channels on it, and it also integrates with the state police and the state system so that we can communicate. The other thing is that the electronic world can go down. So the big thing is we also have hard lines in the EOC so that we have communications. And then when all of that fails, the big thing that you have to do is still be able to communicate. So we have runners, okay, that will run and distribute messages. The other thing that we have done is that we have a daily briefing every morning in which all those agencies that I enumerated there meet together in the morning. We distribute or discuss the issues that we have had and seen during the previous day. And we also get notices as to what may be in the development because we do work with Homeland Security and the FBI to see if there's any threats to the event. And then we set up that we have a unified command in which if we do have a mass casualty event, these representatives from each of the organizations get together to distribute the information. Our medical operations is that we have on-site medical facilities, then we have local hospitals, then we have our mobile treatment teams that move, and then we have volunteers and ushers. I'm not going to go through all of the different jobs that they do underneath, but just to let you know and see how we're organized. One of the things that came up is, Dwight D. Eisenhower said, in preparing for battle during World War II, they have always found that plans are useless, but planning is indispensable. The problem is that one of the things that I have told our staff and everybody out at MIS is that you have to be flexible, you have to be adaptable, and you have to be innovative and creative because situations are going to come up that even the best laid plans are not going to accommodate. And then George Bernard Shaw said, the reasonable man adapts himself to the world and what happens in it. The unreasonable one persists, in trying to adapt the world to himself. Therefore, all progress, depends on the unreasonable man. So what happens is that we have to really look at what's going on in the world and in our event, and we need to adapt to it, not to try and adapt it and force it to adapt to us. And then Ernest Hemingway was attributed the following quote, but when I did research on it, it's actually Barnaby Conrad, who was a bullfighter. And one of the things is, it's a description of sports because I'm dealing primarily with sporting large events. There are only 3 sports: bullfighting, motor racing, and mountaineering. All the rest of them are just games. And the thing that's interesting about that comment is that he attributes sports to where people can die and get injured as a result. In any system, you have to have a medical contingency plan for the event. And this is what we've come up with. And then the real problem is that when you're doing your contingency plan, is it a mass casualty? Is it a disaster? Or is it just a system overload that you were not aware of or did not plan for? One of the big problems that we have out at Michigan International Speedway is that, as I previously mentioned, we're out in the country. We have no major highways to get into the track or out from the track. So egress becomes a real big issue. So you have to work with the state police. You have to work with the police to have a planned traffic pattern as to how to get out of the track after an event. One of the problems based on that I just said about the traffic is, and the contingency plan, one of the things that I'm working on is actually a reverse type of a plan. Most of the time, when you have a mass disaster or mass casualty, you transport people out. But the problem is, if you're out in the country and have such a long distance, you're not going to have ambulances to be able to transport out for a long time period. So how do you take care of the patients, during that event? One of the things that we do is limit how many ambulances can leave at any one time. Well, what do you do with your most critical care? My reverse thinking is that since we have multiple garages and facilities, is that we would convert one of them into a stabilizing hospital. And what we do is it becomes like a military MASH unit. And what we do is before the race, we have a mass casualty pallet that we arrange with the hospital that is delivered to the track. And then we have a mass casualty, same type of pallet, delivered to the same or to the local emergency department that we primarily use, because you're going to overwhelm them. So you need to have the necessary supplies. I have enough staff out at the track that I can run a little hospital there. And what ends up happening is that if you use helicopters, you have limited in the geographical area how many helicopters you can use. But most of the time, you can only transport one patient out at a time. However, what happens if you have physicians and staff at the hospital that are on call? You can call them. You can transport in a surgeon, you can transport in nurses, you can transport in supplies, and we can treat them. And then when we have the time and the availability, you transport the most critical out of the track. One of the things that came out of the Las Vegas Harvest Fest is that one of the things that they learned at that event with the mass shooting was that the old way is that if you have that, you establish a triage area, and then you have start transporting the patients out from there. What they learned in Las Vegas is that that system does not work. What ends up happening is that you triage either black or red. They're either dead or they're most critical. And then you started transporting the most critical out. There was EMS that were leaving, police that were transporting, other people were transporting those. And what happens is that the normal triage system that we use, the SALT or the START protocols, they break down because it's totally dependent on who's rescuing and who's doing the evaluation. And most EMS people triage based on their experiences. And when you're dealing with someone who appears critical, it is very difficult to abandon them or to say during triage, you have an airway problem or can't do much. You try and position their airway. It's very difficult to abandon that patient and allow them to die. So the new system that developed out of that system is to transport the most critical using all facilities and all personnel available. And then afterwards, then you set up the structured system that so many of us are used to. When running at, and there are certain things that you have to identify in a mass disaster, structural stability, hazardous materials. We have all kinds of hazardous materials at race. Is there a violent armed assailant? And then secondary devices. Those are the ones that we worry a lot at the track. And in the, you evacuate the walking wounded, and then you establish your, triage areas and treatment areas. One of the things that we have learned is our personnel are all emergency personnel, and so they want to abandon the first aid centers or the care centers and go out and help. One of the things that we have said is that they cannot. They stay in their care centers because people are going to be bringing them the patients. And then the medical director wears multiple hats. He may be in the Unified Command Center. He may actually become the triage officer, or he may remain in the care center and provide care. The big thing is that with your personnel at the track, everybody has to have a pre-assigned role. Threats. One of the things that I have said is that they can be bizarre. And all the residents and everybody that I've worked with, I've told them we're only limited by our imagination. Human nature is human nature. What will happen in a city of 60,000 people in a 24-hour time period will happen at the Speedway or at a mass gathering in a 24-hour. And it's not that isn't going to happen, it can happen and it will happen. And are we going to be prepared for it? These are the both the domestic and international terrorism that we have talked about at our group meetings. And then these are the threats that we have considered at the Speedway. One of the things that we've had special training come in for Stop the Bleeding, because in the shootings and bombings that have been analyzed in the United States, 91.5% are hemorrhage, due to hemorrhage. So we have tourniquet training. All of our personnel are provided with tourniquet packets to help stop the bleeding. And one of the things that we've learned is 1/3 will die, 1/3 will live, and 1/3, are unknown. 7.5% are airway and 1% are pneumothorax. Those most likely are going to be designated to be a black unless you can do something immediately to help with them, such as positioning their airway. An MIS Sentinel event I was actually involved in. It was in 1994. Ernie Irvin crashed. He had a significant head injury as a result of it. And as a result of it, NASCAR developed what is called the nurse liaison system. Those are nurses that travel with the drivers around the country. As the drivers travel from one speedway to the other, they may not return home. So we have a medical record that is taken care of by the nurse liaisons. Then the other thing that happened is because of the crash event, and it was life-threatening at the track, NASCAR has used the ambulance service, AMR. They provide an on-track physician in an ambulance, and then we provide 2 backup physicians, 99A, 99B, and 99C, actually 3 physicians that are available. They're sitting waiting so that if something happens. One of our big concerns between Dr. Now, my assistant medical director, and myself is that we see a lot of head injuries as a result of car crashes. And when do you approve for the driver to return back to work? So NASCAR has employed using a traveling neurologist to help us determine that. My personnel and the staff, a lot of them, these are the things that you have to consider. Are they going to be hospital personnel? Everybody that we employ are from all the local hospitals, and I have approved them. They're all emergency medicine personnel. But the things to look at for groups when you're hiring is, are you going to use corporate or organizational personnel, or independent contractors? We're all independent contractors that work for the track. And one of the things that we've learned is that we don't use volunteers, because when volunteers, they use the excuse to get there to the event, and then they have no obligations, so they end up leaving. And then the other issues are in the United States is liability and for the medical staff. I use a platoon system out at the Speedway. In each of our first aid centers or modules, we have 1 physician, 1 to 2 mid-levels, 2 to 4 registered nurses and 1 to 2 technicians. And the technicians, one of them is assigned to be the communicator with the radio there. We also use graduate nurses, and I am an advocate for education and teaching for my replacement and other replacements. So I encourage the residents to come to practice because many of them do not get to see a mass event outside of the hospital or practice outside the emergency department. In the infield care center, these are the staff that we have present. And then at Faster Horses, you can see that it's much less, but different. And this is the staff that we have available. At Faster Horses, we have 2 tents that are in the concert area, and then we have the infield care center that takes care of the rest of the staff and the rest of the campgrounds and everybody else outside. One of the things that we have a lot of problems with concerts, especially the country western, because alcohol becomes the major beverage that everybody uses. So what ended up happening is that the first year that we had a concert, everybody at the emergency department wanted to tar and feather me because I sent between 85 and 100 intoxicated patients to the emergency department to be taken care of. And in the United States, if you're intoxicated and on the street, the police and everybody picks you up and takes you to the emergency department. So what did we do? We essentially did the same thing out at the Speedway. The problem is that overwhelms the emergency department. So what I decided to do is, back in my training in the 1970s in Detroit, when we had intoxicated patients, sorry to say this, we had a drunk tank. We put everybody in a big area. And so what I did was to resurrect that, but in the form of taking one of the garages, putting multiple tents up. We put ropes across put carabiners. Every patient that comes in that we think is intoxicated, we do a cardiovascular quick exam, respiratory exam, check their blood sugars, neurological exam on them, start an IV on them, give them a liter of fluid, and we put them to bed on a cot. We watch them and monitor them until they sober up. Then we return them to their event and to their campsite. And this is exactly what we did. And we don't call them intoxicated, we call them over beverage, to be polite. In such an event, you have to have a policy that we have. And in the United States, you cannot, and in the state of Michigan, you cannot drink legally under the age of 21. So, but in the United States, you're an adult at the age of 18. So how can you tell an adult in the United States that they can't drink? Or if you're an adult, how can you fight for your country and go into the military? So our policy is, and when a spectator attends one of these concerts, it's like $425 for the whole entire weekend. If we catch a minor that is under 18 years of age, we cut their band off. We take them and send them by the ambulance to the local emergency department. And then they have to call their parents to pick them up because you can't have a minor intoxicated that way. That creates a problem because I've had people for the concerts come from the state of Minnesota, Canada, Ohio, and other states, multiple areas that had to come and pick their child up from the emergency department. For those intoxicated patients that are not legal, under the 18 to 21, we treat them as an adult. We put them in the respite bed, and then or we find a friend that they came with, we release them to a responsible adult. We treat and stabilize them. The big thing about an intoxicated 18-year-old, if you let them leave the track and someone gets killed in a car accident, the track, the organization, and the medical staff, we don't have enough insurance that's going to protect us from taking care. So what we have to do is take care of the patient before that event occurs. Resources and supplies for the track, these are just some of the areas that and where we obtain them. Most of them we get from the hospital. Sometimes we buy them directly from. We use a county disaster trailer to be available, and we also use a district disaster trailer. We place one inside at the infield care center and one outside the oval because the track becomes a barrier. This is just where we store some of our medications. Liability insurance becomes a real big issue in the United States. And so we had to make arrangements for the liability. When we're working for NASCAR, NASCAR covers us. When we're working for Faster Horses, everybody's an employee of my corporation called Just Cause Medical Adventures. When people ask me how I came up with the name, I said, why did we do it? Just cause. That's the reason why we do it. Everybody's an independent contractor, and what we do is we have an occurrence policy which protects us, for that event and anything that falls out from that event. Planning for the organization, one of the things that we have found is that we see about 5 to 20 patients per 10,000. And there's a varying, the number of patients that present to our first aid station varies tremendously. A lot of the patients that do not normally get medical care, but come to the track for an event, it's free medical care because the track and our organization pays for it. So what we do is we get a number of patients that we're doing their first initial evaluation and then entering them into the medical system. Number of patients presenting, the casualty rate varies on the size of the crowd, and then heat, drugs, and alcohol. Most of our problems are alcohol, not drugs. And these are the most common complaints. One of the things is that I cannot present our actual statistics from NASCAR because NASCAR considers it to be proprietary data and they won't allow us to present it. I've been trying to talk them into presenting it and allowing us to publish it because there's a lot that we have learned over the years. And these are, the frequencies and the most common medical conditions that we treat at the Speedway. Actually, they also become those that we treat at the outdoor concert. And then these are the medical conditions that we find that we end up transporting to the hospital. At MIS, the incidence of medical problems ranges, from, if you look at the data, anywhere from 0.12 to 6 per 1,000 spectators. And one of the things is that nobody really keeps track of the cardiac arrests and the life-threatening events that occur at these events. But we have found out that we have about 1 cardiac arrest approximately every 2 races. And I knock on wood, we have been very successful at resuscitating people because medical care is so fast and readily available at the track. This is how our first aid centers are set up. Our key attributes are they're easily identified. We provide patient privacy. And one of the things is you have to have a guard or security at the first aid station. One of the things that you would not believe are the fights and things that occur at these events, especially concerts. And then we have gophers that travel between the first aid stations and pick up supplies, resupply, and transport patients back to their seats so that we don't have people waiting around in our first aid stations or infield care centers. One of our on-site physicians, they're all emergency physicians. They have to understand our objectives and what we're trying to do. They have to be confident. They have to be adaptable, flexible, and able to, improvise. And we have a lot of emergency medicine EMS fellows that are now rotating and come to visit our track. NASCAR is a 3-day event. We have the infield care center and then 3 to 4 grandstands. At Faster Horses, we have just the infield care center and 2 first aid centers that are on the footprint of the concert. This is a map indicating the yellow circle inside the oval track. That's where the infield care center is located. The others are first aid stations located in the stands. They're outside because I couldn't put it on the oval, but they're actually in the stands at that location. This is an overall picture of the whole entire oval where everybody is located. All of the yellow dots and stars, the stars are mobile ambulances that are located in the garage, in the pits, and on the track, and then those that we have located outside of the, in the spectator areas. Again, this is a picture of Faster Horses out in the back acreage in a giant field. And this is the footprint that we have for or a schematic of the footprint of the concert area. We have an ambulance in the backstage area, and then we have our 2 first aid stations easily able to leave. And then the green starred area is mobile EMS. One of the things that we cannot have during the footprint is ambulances, and so one of the local fire departments provide the mobile EMS inside on the footprint. And then these are the various types of EMS services. We use a bike team because, and they're what we call an ALS bike team. They can provide advanced life support and wait for a transporting ambulance to arrive. This is our track services. Just with the services and people that are on the track, we have a morning meeting, and then we have practice throughout the year of the different types of, of incidences that we may have. The big incident is practicing helmet removal if we actually have to remove it. And then this is the various infield care centers that we've had. The first aid centers at the Faster Horses. And then if there are any questions, I'm available. There's my contact information on the bottom. And I believe you have a link with all of our presentations. Having been one of the editors for the mass gathering textbook, one of the things that we're always looking for are people that are interested, that want to be authors or contribute. So if you're interested in helping or participating, because I'm sure we'll have a second edition that will come out in the future. And I'm a believer that we're a global community. We need to share our information. We need to work together and share our resources. So I would welcome your involvement so that if we get to go ahead to look at what we're going to produce in the future, you can contact me through that information.
Thank you, Professor Mino, for your talk and speech. Now we'll take 30-minute breaks. and come back at 1 o'clock. We will have 2 breaks. One is for prayer time, and at 2 o'clock, we'll take another break for lunch. Thank you, sir. Yes. Yeah, thank you so much.
As Dr. Mano discussed, our doctrine begins with a standard framework that we call the National Incident Management System. I won't dive too deep into that because it's unique to the United States, but one key component of that is our leadership and operations structure that we call ICS, or the Incident Command Structure, the Incident Command System. And what that is, if you see at the bottom, is a standardized leadership structure that starts with the commander and then has very specific functions underneath it in terms of logistics, finance, administration, and operations. So everybody knows their role, and no person at any rank has more than 7 people that report to them. If one person has 20 people reporting to them, the structure falls apart. Nobody can do that. And so this ICS system works for us and helps us divide the labor. Adherence to this standard ensures that each individual organization uses the same leadership and operational language. Underneath that, we have what we call the Medical Operations Coordination Center, which is a local hub that monitors and balances patients and resources across the healthcare system, especially during disasters or emergencies like the pandemic. This concept really came to favor in the United States during the COVID-19 pandemic in 2020, when we needed regionalized systems to help determine where patients could go to receive care, avoid the overwhelming of emergency departments, ICUs that were filled, ventilators that weren't available. So this communications and command structure of what we call a MOC helped us to distribute patients and resources and avoid a disaster. Because as a disaster specialist, we consider a disaster any time where your patient needs outweigh your resources. And that could be twofold. That can be typically because your number of patients increase or their severity of illness increases as compared to your resources, or in terms of a cyber attack where your resources drop dramatically, but your patients remain the same. So that imbalance is the disaster. A regional MOC extends that view and authority across different jurisdictions. When volumes climb, the MOC directs distribution of patients and resources and helps to keep things running smoothly. Underneath that, in a different structure, is what we call a healthcare coalition. A healthcare coalition is unique, and it's a way that a city or even a part of a city can use all of its medical resources in a unified way. It involves the hospitals, urgent care clinics, EMS, the blood bank, dialysis centers, nursing homes, any organization or facility that participates in healthcare. We have regular meetings of the key people at those organizations so that we're prepared for when those resources are needed and that we're all on the same page before disaster strikes. In terms of a timeline, we think of disasters as, most people think about the response. There's a boom and then everybody responds. But the key, the most important part on a disaster timeline is to the left of the boom, beginning before it happens with your preparation and mitigation, so that when things go wrong, you've done your best to prepare and mitigate against it. Command and coordination require a physical home with power, bandwidth, and an open door. The venue's Emergency Operations Center sits just outside the security perimeter so that agency leads can enter without friction and vehicles can stage nearby. Now, it's always a best practice to have your incident leadership near the action, but not inside the venue, where they may themselves become involved in any major incident. We always say, have your Emergency Operations Center downwind or sorry, upwind and uphill. And so that way, if something goes wrong, they're not involved in the danger themselves. It connects directly with the city or regional emergency operations center and the tournament headquarters. In the United States, we also have a classification system that helps us decide the types of resources that are necessary for large events, that also help us to determine who's in charge, because you don't want to be trying to figure out who's in charge after the boom happens. And so we have a classification system that we call SEER, Special Event Assessment Rating. Now, if you're hosting an event, you can apply to the federal government and they will give you your category of 1 through 5 based on the significance of the event to national security, the attendance, meaning the crowd size and maybe who that crowd is, potential threats to public safety, whether that is intentional violence, circulating infectious diseases, weather, infrastructure impact, meaning what is going to happen to your infrastructure due to having the event in that area, whether that's people destroying property, overwhelming of a transit system, things of that nature, and then visibility. How many people are watching this? Because we all know that's important in terms of how our leaders behave. And then based on that event's assessment, it's given a score between 1 and 5. And you can see here, and we'll start at the bottom, what the definition is and how we have some examples of that from the United States. So starting with a SEER 5, which is the lowest level of importance, that event may or may not be recognized nationally, but it's usually like a local sporting event or a county fair or something small like that. Some of our college sporting events, which don't have more than 5 or 10,000 people. A SEER 4 rating is going to have maybe some national importance and is handled by a state or local government. They're interested because there's a lot of people there. Going up the next level is when things start to get a little bit more interesting in terms of planning and whether or not the federal government gets involved. There's a nationally important festival like the Masters Golf Tournament. There's a lot of eyes on it. The national television is there. It may be internationally broadcast on TV. A SEER 2 is a nationally important event. It may require some federal support. It may require funding from the federal government to help make sure your infrastructure is appropriate. And that includes things like this huge race called the Indianapolis 500 or the horse race called the Kentucky Derby, some of these big annual events that people love to go to. SEER 1 is when things get real. A SEER 1 is the top tier of event that doesn't have the president present. This is significant national or international importance. This can require extensive federal interagency support, law enforcement presence, and that includes our NFL, the National Football League Super Bowl, which is our country's biggest sporting event every year. It can include things like the Boston Marathon, which can have up to 1 million spectators over that 26-mile course. And then the highest tier of event that we have in the United States is called a National Special Security Event. And that is typically a SEER 1 event in which the president, the vice president, or maybe the next level of leadership are present at the event, so that there now are severe security concerns. As we know, when you have an official who's present and 80,000 people, half of whom may really disagree with what that person does, there's always security risks that have to be considered. So NSSEs are few and far between. When the Pope came to America and millions of people came to see him, those types of events are considered NSSEs. What that means is at that point, the United States Secret Service is in charge of the event. All planning and security have to go through the Secret Service. Communication is the nervous system of the entire enterprise. Plans are built with PACE, as I talked about. PACE is an important way to think about things in terms of planning for an event, but it's also how I teach my residents how to manage medical issues like a difficult airway. So PACE stands for 4 ways that you need to be ready for a situation: the primary plan, the alternate plan, the contingency when things fall apart, and the emergency when everything else has failed. In terms of an airway, right? Your primary, let's get the glide scope. We'll look in there with the camera and gently place our endotracheal tube. But if that difficult airway is not amenable to the glide scope, you go back to the old way with direct laryngoscopy, using your eyes. There's more mistakes that can happen. That's why it's your alternate. Then when things fail and you can't intubate that patient, you're going to get an LMA, the laryngeal mask airway that doesn't go in the trachea, to breathe for them for a while until you can get them intubated again. That's your contingency plan. And when all else fails, now you've got to do a cricothyroidotomy. You've got to cut their neck open. That's your emergency plan. So when you're planning for a large-scale event like that, keep PACE in your mind: primary, alternate, contingency, emergency. When you're planning for your communications, when you're planning for your transport of patients, when you're planning on everything, always have a backup and a backup to your backup. So what drives volume of patients at these events? With governance and communication in place, we describe the risk picture that shapes medical demand. 3 elements dominate: the crowd, the environment, and the venue. Crowd risk is not only how many people arrive, but how tightly they pack, how they behave, and whether alcohol is available. Environment risk comes from heat, humidity, and the availability of shade and water. We tend to avoid mass gathering events in the United States in extremely cold temperatures, but they do happen with NFL games in the northern states, but typically people are dressed more appropriately for that. Venue risk is the geometry of the movement. It's where the lines form, where the choke points create pressure. It's the length and the slope of the ramps, the presence of rails, and how quickly gates can be opened to relieve the pressure of those crowds. Facing these risks early is the only reliable prevention. Upstream controls, metered inflow, shaded lines, water distribution, and well-placed barriers lower the floor of harm before a patient ever appears. Now, staffing and supply, those hinge on defensible benchmarks and honest scaling. There's no accurate matrix that we can use to determine the staffing or resources based on attendance predictions only. I heard Dr. Mayno get asked this question during the break. When do we know how many doctors, how many nurses, how many paramedics need to be present at an event? Well, common sense would tell you that, oh, if there's 100,000 people, you need this many doctors. If there's 500,000 people, you need this many. But that never accurately works. You either overestimate or you underestimate. Where I've worked in Washington, D.C., I've been medical director of small events that had a few thousand people. The largest event I was medical director for was called the March for Our Lives. It was a large firearms control rally. We had 850,000 people outdoors in the streets of Washington, D.C. So we overscaled for that. We had 13 medical tents in the streets, geographically distributed. Each tent was a full ALS ambulance with intubation, defibrillation, all the medications that you would possibly need, the controlled substances, and ambulances. And we needed all of that for 850,000 people. But still, there's no matrix that could really tell us exactly how to do that. That number is a starting point, right? So the only data we have that's really addressed a matrix that can help us predict is this Japanese study that reviewed inside the stadium care, where they showed a patient presentation rate of under 2 per 1,000 people. So you can reliably use that for a stadium. And then the transfer to hospital rate is actually quite low. Very few people ever have to go to the hospital, but it's not insignificant. The average NFL stadium, the football stadiums in the United States, are about 75,000 people. So there are a number of people that go to the emergency department every single event, and you have to prepare for that with your ambulances. Obviously, heat and alcohol policy and crowd density will upscale that. And the most important factor of this that I'll reiterate later is when you have this data for the event, share it with everybody. Publish it, even if there's ugliness and mistakes that you've made. Do your best to share that so that the next person, the next group that's trying to plan for that event has a better chance of success. So they're not reinventing the wheel, as we say. So the venue medical architecture is also important. It's good to have doctors and paramedics and nurses, but where do they go and what do you do with them? On site, the architecture is consistent. It should be a main clinic with short stay chairs so people have a place to sit, because not everybody needs to be laying flat on a gurney. You can fit far more people in chairs. Very few people need to be laying down in an event like this. You want to absorb the low acuity patients and distribute those first aid posts near high traffic areas. You need a way to go out and get people. You need a way to go out and get that person who's having a seizure, that person who's having chest pain, that person who stepped wrong and broke their ankle. They may not need to be in an ambulance to be transferred right away. So we have these things called UTVs, different ways to go out and bring that patient to us. We also have roving bicycle teams for people to get through the crowds. And we try our best that when we're sending a medical team into a crowd, that they have a large sign with a flag on it so that we can see where they are above the heads of the people. Supply and pharmacy, it's boring. It's very boring. I'm sorry if there's any pharmacists here, but this is the most boring part, but it's critical. It's critical that all this is in place so you know you have safe, sealed, sterile supplies when you need them. You've got your resupply routes pre-planned. Now that's typically going to be for water. It's going to be for Band-Aids for people with blisters on their feet. But you want to make sure that when these heat situations arise, that you've got your resupply routes already determined. In terms of public health, now for most events and most World Cups that I've found research on, it's always a consideration about public health, in particular disease transmission. Those of you in this room are the experts in planning for pilgrimages and the large influx of people that come to your country from other countries. And I know that you have baseline vaccine requirements and then the enhanced vaccine requirements depending on countries and where they come from. I think that's brilliant. In the United States, we definitely don't have that. In fact, for short stays like what we have where people will be coming for the World Cup, there are no vaccine requirements. And that won't even be considered in our current political environment. And that brings us risk. We will be having patients that come in from areas where yellow fever and polio may be endemic. And so there is some risk there. Now we counter that by trying our best to reduce crowd densities, and we have surveillance active at all times. So whenever you have your medical tents and your first aid facility set up, if you're starting to see syndromes, you're starting to see multiple patients with the same presentation, that's a trigger to the public health departments to be mindful that there may be something happening. But it's not just about syndromic surveillance, it's about making sure that you understand that the number of people coming to your event are coming from dozens and dozens of different countries. 46 different countries for the World Cup are going to have teams of their own, let alone the spectators who are coming from countries where their team is not participating. Everything has to be multilingual. Not everybody speaks English, although most Americans think they do. Cooling zones are critical in summer months. I'm not going to tell you how to manage heat. We learn from you how to manage heat. But we run into problems with heat and shading throughout the United States, and we do our best to make sure that we've planned for that. We talked about vaccination precedents and options. Prior hosts rarely add new vaccine mandates. They lean on their standing rules. South Africa, Brazil, Russia, and what I found information from Qatar did not necessarily require an increased number of vaccinations or proof of vaccination. In 2034, keep general rules and add targeted requirements as your experts see fit. Now, what's unique about the World Cup for us compared to the every Saturday football games that happen across the United States? It's about the tournament scale and the tournament tempo. You have teams that are playing multiple games over a short period of time, and the stadium itself is having multiple games in a short number of days, not just once a week, maybe 5 days a week, there might be a game at a venue. And what else is really interesting about the United States and this World Cup in particular for us is that it's not just ours, it's Mexico and Canada. It's a 3-country World Cup. The US is big enough. The distance from Boston to Los Angeles, I mean, that's a 5-hour plane flight. And so being able to coordinate the communication and the different aspects of sort of that federal and governing oversight can be very difficult with those sorts of distances. So we've regionalized things the best we can. Fan zones and training sites will be basically standardized across each city, the way FIFA runs it. There will be mocks and regional mocks that exchange the capacity information and help try to keep things organized. We also understand that with FIFA tournament in particular, morning is the right prep time because most of these games will be taking place in the evenings for us. VIP attendance always complicates your plans, especially if it's not anticipated ahead of time. Currently, we get a lot of surprises in the United States as to when our leadership may or may not come to an event, and that could be on very short notice. And if the people with the highest security requirements in your country show up sort of unexpectedly, that can really have an effect on your plans, so you have to think ahead and really know if that's going to be a possibility. Number one, it's because the security posture jumps immediately. You have to reshape your command and your access timelines. When a political dignitary or a head of government attends, the event risk rating for us immediately increases into an NSSE, and that brings Secret Service liaisons to lead the show. Layered screening, people have to go through magnetometers. Some people may not be allowed into the event. There will be what we call sterile areas where civilians cannot go into because you're too close and could bring harm to those dignitaries. The unified command adds agencies, and that slows decisions. Credentialing tightens. Your radio discipline changes. Your rehearsed medical plans that you anticipated go out the door. If there's a sterile pathway that you can no longer cross and you have a patient to evacuate, you have to have that alternate, that contingency, that emergency plan on how to transport patients. The entire flow of your city can be changed by these events. One thing we know for sure in the United States from data is that if you have a marathon, for example, in your city, a 26-mile run through the city that has all sorts of traffic blockages, people have a higher mortality rate from a cardiac event for the whole city because the transport times to your hospital are longer. So forget about the people at the event. The regular citizens living their day-to-day life in your city are at a higher risk of poor outcome if you don't plan ahead for how to get around those transport disruptions. Clinical operations can also take a hit. Those same delays mean that your staff may not arrive in time. If you need to call in backup staff for a disaster that you're not expecting, expect that they're going to be delayed because the trains are blocked, the streets are blocked, the crowds are already taking up transportation. So when you're writing your plan for a VIP, use PACE. Plan for how to get around things. Make sure your communications are well established with a primary radio net, an alternate shared channel. And if those aren't working, by text or cell phone, or even physical people running with messages. For us, in the way that we'll be running our World Cup, the fan experience is so important, but brings a lot of logistical challenges and medical challenges to us. Alcohol will be restricted here. It was restricted in Qatar. The cities in the United States where drinking alcohol is such a huge part of the sports culture, every state will have its own alcohol rules. But what I can tell you so far from what we know is the only changes that are being made to the alcohol rules is how to increase access to alcohol, extending hours of service, complicating things even more. If you've ever been to a sporting event in America, or even the UK, I mean, you understand how big alcohol plays a role in not only the event itself, but in the behavior of the fans and the mob culture that can happen whenever that occurs. So we know that after the events, nightlife surges. People don't go home. People are going out to party. Your areas with restaurants and bars and other places where people gather will be overwhelmed. You can't just make all your staff go home and dismantle all your first aid tents as soon as the event's over because people are hanging out, especially if there's fan zones. And you need to know how the peak ingress and egress times of the fans is going to affect your transit. So as I said before, I think it's extremely important for organizations to not just publish their successes, but to talk about when things don't go as planned. And so I'm going to tell you about a near miss that we had during a large soccer tournament called the Copa America tournament that we hosted recently. We under-anticipated the behaviors of our visiting fans. There was significant strain at the gate, and there was medical surge happening throughout. Our security holds, our medical surges overlapped in a way that felt avoidable in hindsight. 5 minutes. Okay. So what we had occur at our event, and I'll show you this video, is that at one of our events, we had thousands of fans that were gathered from other countries, broke through security. These people didn't have tickets, and they overwhelmed our stadium. Right? We didn't plan for this behavior, and this isn't alcohol-related behavior necessarily. And so these people came in without tickets, disrupted security, and could have brought in weapons or other problems that it could have been a major issue. People were climbing through the air conditioners. People were stealing seats. This happened despite our security. So plan for the unexpected, no matter how well you think you've got it lined up. Now, crowd surge is really important for large events. When the density reaches 5 to 6 people per square meter, humans become a fluid. You can see the fluid wave happening in this crowd. This is uncontrollable. This is how vertical asphyxiation kills people. This is how crowd crush happens. AI is going to help be able to help us model this, and you have to have plans in place, as I know you do, to help restrict the crowd inflow. This happened in South Korea recently when during Halloween, people were just in the streets, but they were flowing in the wrong directions. And many people died just because they were stuck and crushed between the walls and the streets. And this was in a country with lots of technology, lots of medical resources. In the United States, we had a concert a few years ago at a place called Astro World in Houston, Texas, where a rapper was on stage. It was very loud. The whole crowd rushed to the front of the stage to try to get closer. And the next thing we know, people died. Kids died because they didn't plan accordingly. They didn't plan that people wouldn't be able to hear the emergencies. There were no lights. There were no stop the show signals to cancel the event. And those things have to be in place to prevent crowd crush. There has to be a preparedness playbook for the heat illness ideas. Heat plans start with prevention at lines, with shade, watering, and misting, and having chairs for people to sit. I'm going to hurry along since my time is running short. Communication is the key, and it's the failure point for every mass gathering. Your failure plans have to assume both intentional and accidental disruption. They can be overload, communication errors with the configuration, or it can even be a cyber attack or an intentional cut of your fiber wires. The countermeasures need to be in place so that you've planned ahead, because domino effects will lead to major problems. So let's talk about some of the common pitfalls as I start to wrap this up. These pitfalls repeat across events and deserve explicit attention. Activating your medical operations center too late turns a manageable surge into a real distribution problem for patients. Skipping short stay capacity instead of having gurneys everywhere, that forces unnecessary transports to the hospital, and it clogs up the emergency departments, when our primary role of having these pre-hospital tents is to offload the emergency departments. In Washington, D.C., we do this well enough that when we have these events with hundreds of thousands of people in the streets, we do not increase the number of doctors or nurses in our emergency departments. Not one. We do not upstaff. We put them all in the pre-hospital environment, and we could absorb whatever few patients come our way. Unclear radio maps and untested fail-safes, they leave teams improvising when you should not be improvising. VIPs can lock everything into place where you can't move, and they'll expose gaps in your pre-positioning if they're not considered ahead of time. Each pitfall has a simple remedy. Write activation triggers into your plans on when to take a particular action. Use chairs, not gurneys. Publish a one-page plan for all your radio communications that everyone knows, and rehearse a VIP situation with the same discipline as you would for an MCI drill. And keep in mind, The work is not finished when the final whistle sounds. A formal after-action report with an improvement plan closes that loop. Findings should be written plainly, and corrective actions should be assigned to owners with deadlines, and methods and metrics are published so that others can learn. Transparency is the mark of a confident system. Publishing how we calculated patient presentation and transport rates, how we measured queue time, and which definitions we used, it enables honest comparison across venues and across World Cups. Standardizing those definitions is very important, and it'll be a kindness to your future self as you're trying to do your after-action report. So I think there's 3 practical moves to take away from this. For any host preparing for a future tournament, 3 moves will travel well. First, test your backups for real. Have exercises and drills where you cut the primary radio channel, you cut your internet, you force teams to switch to the alternate, maybe even the contingency. Muscles learn by doing something repetitively. The second thing is to own the radio spectrum and the cellular capacity. Every one of these events will have a cell phone. Everyone will be recording video and trying to transmit it. Everyone will be soaking up the bandwidth. So no matter how well you've planned for your telecommunication structure, you need more. Portable towers. In the United States, we have something called FirstNet, which is a dedicated bandwidth across the United States where emergency responders have access to that and the general public will not. Third, design operations to work offline. Patient tracking and incident forms should function without the internet. A small paper kit, pencils and paper, they still work. They will always work. You can always go back. It's not flashy, but it's bankable. In sum, medical preparedness for mega events is a choreography of decisions made early, pathways kept simple, and systems designed to bend and not break. The US model is not unique. It's merely consistent. A unified incident command that acts quickly, a regional coordination layer that balances loads for patients, and a coalition that can move resources. We have communications that can fail and a habit of writing down what we learned so that the next venue, the next city, and the next host country start closer to the finish line. The framework scales to a multi-city tournament and transfers to any setting where large numbers of people gather. The promise to the public is straightforward. We will prevent what can be prevented. We will recognize trouble when it's still small and keep care moving when the unexpected happens. That's the end of my talk. If you'd like to get in contact with me, use your phone bandwidth. QR code will take you to my email address, my LinkedIn. I'm happy to meet with anybody afterwards to talk. If we can be of any service to you as you're planning ahead, if you need any advice that we can provide, I'm happy to help provide it. I want to thank Dr. Eric Gorelnik, who's the Boston Stadium coordinator, and the National Medical Director for FIFA 2026, Eric Osman, who is also a resource for me when putting this talk together. Have a great time. Thank you.
Thank you, Dr. Phillips, for that amazing presentation. Our next speaker, Professor John Maino. He will talk about the evolution of mass gathering medicine in the United States and the possible strategy and application that we can do it here in World Cup in 2034, inshallah.
Hello again. You may be looking at my slide, but you have to have a little bit of a sense of humor with what we're dealing with, because a lot of what we do is with mass gathering is potentially dangerous to our spectators. One of the things that I want to say is I may be presenting more information than I can cover in the slides. I know that at the conference they have a link, so I provided as much information as I could for you. Secondly, before I did this lecture or research this, I have to be honest with you, I did not know a whole lot about the World Cup and how big it really is. My disclosure again is, you know, I contributed to this as an editor to this book. And then these are again my credentials. And what happened is that there are 3 organizations with mass gathering, especially that is going to affect the World Cup. Is going to be the World Health Organization, the National Association of EMS Physicians, and the American College of Emergency Physicians. World Cup defines a mass gathering as a number of people attending, you know, to sufficiently strain the planning or the responding resources of a community or the hosting nation. And the National Association of EMS Physicians, however, they say that the anticipated patient volume of an event, risks and risk profile justifies a dedicated medical teams to be there. And the key element is, you know, it's a large crowd size. However, as I pointed out in my previous lecture, is that that can be variable depending on the number of people there. And it's going to have a number of risk factors associated with it, and it's going to occur in a fixed amount of time. Mass casualty incidents, the definition, the simple one is it generates more patients at one time than locally available resources can manage. And what happens is that in any mass gathering event, we have to potentially be prepared for a mass casualty event occurring. Again, the primary purpose is to just provide expected medical care as needed, and the secondary purpose is again to be prepared for mass casualty incident. The problem with a mass casualty incident is that it actually is a disaster that occurs. And so what ends up happening is you have to come up with a system that's going to have triage, what casualty care are you going to provide, and then EMS transport for definitive care. One of my perspectives is that we're a global community. Mass casualty events occur, or mass gatherings occur all over the world. And what we need to do is to share the information and lessons that we learn. We need to publish as much information that we can concerning these events so that future events we can share that information. And we also need to share resources. Again, I'm going to point out that it's a show business medicine type of a situation. It's entertainment. You have very important people, the spectators that make the event what it is, and then the actors, which are the teams, the players, the managers, the owners that are the actors that put on the show, and then the rest of us, the medical personnel, EMS, fire security, law enforcement that are the supporting staff. These are all the structures that make up the mass gathering. The character is we have to be flexible, adaptable, innovative, and creative because the best laid plan can go astray. Spectators, even for sporting events such as the World Cup, they have an emotional experience. They all get fired up. They represent their country. There's a social connection between all of them. They want to feel comfortable and secure, and they are dependent on the quality and the professionalism that we of the show that we put on. And there needs to be a freedom of expression to express, to wear their shirts, to say, you know, to sing their songs and everything and their anthems. Historically, mass gatherings have been going on forever. We've had coronations, we've had festivals, all throughout time. But the early time when there's been medical care provided during a mass gathering actually have come out of wars. And the first noted time that it's been documented was during the Napoleonic Wars in Europe, when Dr. Jean Larrey, a military surgeon for France, introduced the flying ambulance, which was just a horse-drawn wagon to pick up the injured and the decedent. He also provided on-site medical care right during the battles or right soon after the battles. And that was actually the first start of medical care being provided at mass gathering. Historically, what ended up happening after that is the next big thing that happened was the American Civil War, in which we actually documented using ambulances, which were horse-drawn ambulances and wagons. Then during World War I across the world, they used both, continued to use horse-drawn ambulances, but it was the introduction of the automobile. And at that point, they automized the ambulance. And then during World War II, they used motorized ambulances. In Korea, during the Korean War, they introduced the helicopter. And then in Vietnam, and also in Korea, they had the MASH units, which was the mobile ambulatory surgical hospital. And then in Vietnam, they called it the mobile ambulatory medical units that treated everything. And that's when they specialized and developed really the use of helicopters. What we don't realize is the impact of war that has had on mass gathering. And these are the similarities that I put in there. The venue, the battlefield, in the rest of the world, it's the event. The participants, soldiers. The rest of them are spectators, athletes, and are participants in concerts. Treatment, medics during the war, EMS, during our public venues. Stations, the MASH units, the MAMUs, okay, and our first aid centers, and then transport, the ambulance and ambulances. We all used helicopters in all of those events, and we also had field hospitals, and then we have the community hospitals that we used in the first aid centers. So there's a lot of similarities, and essentially that's where mass gathering essentially grew out of. In the home front, previous to the 1970s in the United States, the 1966, the National Academy of Science report indicated that accidental deaths and disability in the United States was a neglected disease of the modern society. I think that actually occurs anywhere in the world where you had automobiles. And then the white paper came out. They identified accidental deaths and injuries was the #1 cause of death and injury under the age of 50 or in the youth of our populations. And then it was identified during that same time that injured patients, and severely injured patients in the United States actually would receive better medical care in the combat zones than they did in their own communities and community hospitals. In 1969, we had the Woodstock Music Festival and Art Fair that occurred in New York. And at that point, there were 400,000 to 500,000 people. And at that point, there was no medical care that was provided at the scene. And it revealed that there was a definite need for that. And then in 1971, when I graduated from high school, the Service Act activated the EMS and the regionalization and standardization of training in EMS. And EMS actually becomes part of the backbone for mass gathering medicine. The tragedies that ended up leading and prompting changes that occurred in the 1970s was in 1971 was the Ibrox disaster in Scotland. And that was a stadium crush injury in which there were 66 deaths and 200 injuries. And then in 1989 was the Hillsborough disaster in the United Kingdom. That was an overcrowding situation in which they did not, and that occurred during a World Cup or a hockey Cups tournament in the United Kingdom. And there were a number of deaths and injuries as a result of that. And then the important thing was in 1991, the Hajj stampede, in which there was 1,400 deaths that occurred. And then in the 1990s, the big thing that we started to see was the big emergence and related emergencies related to drugs, primarily at music festivals. One of the things I wanted to point out is that you have an event and then you have an incident. And the whole thing that is going to make the event safer is that you're going to have practice. You have to have a plan that how are we going to respond? What are we going to do? And what we do is our reaction is to respond and to control the chaos that occurs around the incident. This is a diagram to show the various types of mass gathering events that occur. The most common one is an urban one in which you have a city, you have the event within the city, but then you have the structure, the EMS and the hospital system within the city that proposes or that responds. And then you have what we have out at Michigan International Speedway. You have the remote cities that are located around the event and hospitals. And what happens is that you have to transport between them. And then what I call the migratory mass gathering. These are the road rallies that we see like in Baja, Mexico. The Hajj could also be part of that, in which you have multiple cities that are involved with multiple medical infrastructures within those cities, but you have a migrating, moving event that moves between them. And then the last one that I have there is kind of sort of the what I would expect in the World Cup situation. You have multiple cities that are involved. You have multiple events or events in each of those cities, and then you can have events outside. And what happens is that all of these events, there has to be an integration of the communications and an integration of the EMS in those systems. Continuing with the historical evolution, in 1984, the National Association of EMS Physicians was formed, and they were primarily interested in regulating EMS and setting up standards, but they also became very interested in mass gathering medicine. And in 1989, they published their first EMS standards for it. In 2010, those standards were updated and to become more aligned with the global events that we're now seeing. ACEP was founded in 1968. It was an organization to recognize and organize emergency physicians. Initially, it started out in the United States, but now it has welcomed emergency physicians from all over the world. And again, it's a purpose for sharing information and what we can how we can educate ourselves to the various experiences and what we have learned medically from around the world. And it primarily collaborated with the National Association of EMS Physicians on mass gatherings. Again, here is just a diagram for ACEP of all the various integrating sections and how it overlaps with event medicine. When I say event medicine, to me, it's a synonym between mass gathering medicine and event medicine because you really can't tell the difference, and it's always surrounding some type of an event. The World Health Organization became really organized in the 2008. Its first guidance came out at that time, but they were primarily responsive and they were more interested in disease alerts and communicable diseases. And in 2011, it, in conjunction with Saudi Arabia and other agencies and countries, recognized that mass gathering medicine was a discipline of its own. And in 2015, it published its public health, for mass gathering events. They also came up with a guidance as to when to cancel or postpone and modify mass gathering events. And that's very difficult because once a mass gathering event is put in motion, it is very difficult to stop it. In 2004 in the United States, the National Incident Management System was introduced. It developed out of the disasters and the catastrophes that occurred with 9/11 and the hurricane in Katrina. It was developed by the Departments of Homeland Security in conjunction with FEMA. With sporting events, it became utilized for coordinating multi-agencies, EMS, and formalizing the mass casualty incident planning for those events. And it centered, and placed focus on crowd density, weather, intoxication, and high risk factors that affect mass gatherings. Out of the NIMS, the National Incident, came what is called the Incident Command Center and Unified Command. Unified Command actually is a little bit different from Incident Command. Incident Command would be, let's say, in California, you have primarily the forest fires. And so what you would do is have one fire chief that is in charge of coordinating multiple fire agencies across the region. In Unified Command, you would have a representative from fire, EMS, medical, working together in a disaster. And then these are the various organizations that work underneath Unified Command and then report back to Unified Command, and they coordinate Unified Command coordinates all the activities of everybody responding. In the 2000s, to 2020s, the major events, the Sydney Olympics, the 2002 World Cup, the SARS incidents, the Athens Olympics, in 2009, the H1N1 pandemic and the disease surveillance. That ended up the globalization of public health and how it affects mass gatherings. And today, the contemporary is, again, related and primarily concentrating on, high-level surveillance of infectious diseases, and also in multi-agency responses to terrorism, such as the 2013 bombings in Boston Marathon bombing that occurred. The importance of the National Incident Management System in the United States is, it is a standardized approach. And what it did was it introduced one central command system that organizes and dictates or coordinates all the response to the incident. And then it does resource management for the event. It placed importance, as I previously mentioned, on dispatch and communications between all the participating agencies that occurred, and then the command coordination. And the system is set up to be flexible and to scale up for various, it can be a local accident or disaster that occurs in a small community and can be mobilized to becoming a nationwide disaster response. to an incident. The World Health Organization, and what you'll see is that there's a lot of overlap between the organizations. There's risk assessment, multi-sectional coordination, surveillance and early warning, a device, health services and infrastructure, emergency preparedness and response, and then the public health. They all have instructions as to what they recommend. There's a communication strategy. There's a post-event evaluation, and with the World Health Organization, I think that this is very important because it evaluates the effectiveness, it identifies and documents problems, and if you document those policies and problems, we need to share it. We need to educate and share it so that future plans can be developed to avert disasters and problems. And then it comes up with how to support the support tools and the guidelines for future events. FIFA for soccer essentially does the same thing. They have a risk assessment and profiling. What are the risks? Because it involves multi-nations and multiple cities. They have a medical service architecture and what they recommend. They have a health surveillance system that is set up and recommended for early warning and prevention. They have an emergency response and mass casualty incident planning recommendations. And then they have medical command. You can see how everything is overlapping and how we have learned from each other and how we have set things up. Then there's a health promotion and disease prevention. Both FIFA or FIFA, I don't know how you actually pronounce it, and the World Health Organization pay a very close attention to disease prevention at their events. And then there's legacy and evaluation. Again, publication and posting of what we've learned from that event. Go to the next slide. As I said, I did not really know a whole lot about the World Cup when I started. And what I ended up finding out is, and made this table is, the games per day, the group stage, there are 3 to 4 games, per day. The knockout stage, the games per day is 1 to 2. The tournament duration is 29 to 32 days that you have to. The total matches are going to be 64. The total spectators, approximate 3.4 million spectators are going to attend all of these events. The average attendance per match is 53,000 to 55,000, and the match championship is around 90,000. So these are big, large sporting events that have been set up. The medical structure, infrastructure is there's a central on-site emergency medical, and then multiple satellites, and then there's a dedicated medical access routes. That is access routes to each of the first aid stations within the event, but also outside of the event, outside of the stadium, in the zone plazas, and how to transport patients to the various community hospitals that will be supporting the event. I'm not going to go through the staffing. However, someone asked me earlier for an event, how many ambulances would you have? And one of the recommendations is that there is 1 ALS, unit per 10,000 spectators, and then 2 basic life supports per 10,000. So that's 3 ambulances available for 10,000. That is a suggestion. What ends up happening is that we have to adapt to the situation, and depending on the location, that may vary. And then air medical access for highly critical that need short transport. And one of the things that I have learned as a flight physician in the hospital that I used to work with and provide emergency care, and then the University of Michigan, what I learned is that you can if you have a patient ready to be packaged and transported with an ALS unit going lights and siren from our hospital to the emergency department at the University of Michigan, it took 25 minutes by ambulance. The air ambulance, by the time they transported to the hospital, they got their clearance from their medical control at the hospital, packaged the patient, and flew back to the University of Michigan. It was exactly the same time. Okay, so what ended up happening was we cut down on air transport because of the cost. However, when you have an event at mass gathering, you need to take into consideration all that type of logistics and planning. How long is it going to take you to go by ALS to the hospital? How long, and is there an advantage to using a helicopter and air ambulance? Again, I cannot stress it in these events. Medical command, having a medical command and EOC are most important. And there has to be two-way communications between all of the teammates that are providing care. FIFA also has, hospital coordination, the logistics and support, and then documentation, and again, the reporting after. The medical records at all of these places need to be standardized so that people are able to communicate, and so that you are recording all of the same data. I created a scenario for the medical staff model and World Cup using the various recommendations. And for an event of 150 attendees, the staffing breakdown and role, this is what I came up with. I'm not going to go through, each one of them, but, the nurse assistants, we came up with the research that I found was, one per 7,000 to 10,000 patients. Registered nurses, one per 2,500 to 5,000 attendants. Paramedics, one per 1,000 to 150. So your biggest number of personnel that is going to be there is going to be EMTs. And that's going to vary, depending on the research that you do and looking at other past, events. Emergency physicians, really, you should probably on site have one per 10,000 patients. And again, the nurse practitioners there. And then the other thing is to have a medical, like pharmacy at each of the major institutions. And you also have to have various first aid stations. The planning assumptions is that you're going to have, one patient per 1,000, 50 patients per 50,000 spectators that you can plan on taking care of. And if there's heat, okay, and overheat, heat is going to increase it to, actually, it's going to be between 2 and 3 patients per 1,000. And you must expect approximately 100 patients in a 50,000 spectator event. Transports, it's going to be about 1 to 3 per 50,000, and the baseline is going to be 2 to 4 per enhanced, which is heat problems. This is a diagram that I came up with after looking, at the stadiums that they will have. You have to take care of the fan plaza on the outside, which should have an ambulance station there, and that's where the bike teams are going to become very important. And then you have one main medical center, and then on each of the levels, the main level, you have 4 first aid satellite stations that are stationed, and then on the upper level, you have at least 2 first aid stations that are set up to respond and take care of the patients. The patient presentation rates, according to the National Association EMS, normally is 0.5 to 2 per thousand. And then these are the other studies, the Australian study, the Rugby World Cup, and then the baseball. And you can see that there's a variation depending on the event and the environment and the circumstances that occur. With heat-related incidents, it's going to increase at 3 per 10,000 for every 10 degrees Fahrenheit increase in heat index. I know you guys use centigrade. I didn't make that calculation, I'm sorry. The ratio is 1.2 to per 10 unit increase in heat index noted. EMS transports, these are some of them from the various studies that have occurred across the country. And it's very difficult, and they usually use 10,000, how many transports per 10,000 attendees. And the Australian study is the one that comes out quoted most of the time is at 0.3 per 1,000 attendees. I took into consideration, I was told in 2034 where the various events, a World Cup would be set. And so I set up one for the King Solomon International Stadium. And this is what I came up with a plan for it based on a 92,000 capacity. And these were some of the suggestions that I came up with. And I also did it for the King Solomon International Stadium, the Prince Mohammed bin Salman Stadium, also with 49,000. And that is the history of mass gathering and whatnot. The big thing is that the mass gathering event, it's an interdisciplinary field, involving EMS, public health, epidemiology, and disaster medicine. We need to focus on multi-agency coordination, surveillance, electronic surveillance, digitalization of the information, triage, environmental safety, and infectious disease. And one of the things that I did not put on there is the possibility of terrorism that occurs. So, and then that's my contact information. Thank you.
Thank you, Professor John, for the interesting topics. Mainly the last few slides, it was an amazing, actually. Thank you. We'll have the lunch break now for 1 hour. Okay, thank you.
three vision for Expo 2030 and FIFA World Cup 2030. Saudi Arabia is prepared to host Expo 2030 and FIFA World Cup 2034. We already run one of the world's toughest mass gathering operation every year. That model keeps enormous crowd safe, moving and cared for, and it can scale to both city-wide expo and stadium center tournaments. Our aim is simple: deliver safe, seamless, heat-smart health services that inspire the world. Our objectives: to prove that the Hajj health model is tested and scalable. I will not talk much about this because in the morning session I mentioned a lot. Translate Hajj lesson to Expo 2030 and FIFA 2034 event and specify what to invest in now and the operating playbook, set the roadmap and KPIs and key risk mitigations. I'll jump whatever Prof. James mentioned and I mentioned in the morning session. We are after lunch with after heavy lunch. I don't think that we can concentrate much. Expo 2030. The event profile, it is a 6-month activity will be run in Riyadh. During that time, we have a hot weather, then very cold weather, then a hot weather. So we will run over different climates. Crowd will peak around establishment day. Around the establishment day, and the VIP visitors will make crowd also. Visitors will turn over quickly across the transport hubs and national pavilions. All of that means we need city-scale health services, emergency management, and strong public health coverage. Our health operations plan for Expo 2030 will run a health command center side by side with Expo operations. So decisions, incision command, and situational awareness happen in one place. Care will start with virtual first through dedicated Expo channel on 937 and Siha Virtual Hospital. On the ground, we will use the distributed footprints, microclinics, mobile urgent care boards, and surge beds, so help is always close to the visitors. The site itself will work smarter, shaded corridors, cooling or heating zones will be available. As I mentioned, because it will run on 6 months, the weather will be changing from very hot to very cold. The FIFA World Cup 2034, the event profile, stadium-centered surge will roll across multiple cities. We will manage player care, anti-doping, and beachside emergencies. Crowd will concentrate at airports, rail stations, and fan zones. Match days will run on tight windows and rapid turnarounds. The health operations plan for FIFA World Cup 2034, the stadium medical rooms will be standardized and directly linked to nearby trauma centers. Beachside response teams will carry full resuscitation capabilities. EMS ring will surround each venue with helipad, air evacuation coordination, and dedicated route for rapid transfer. We expect a fast result, seamless care from the field to definitive treatment. The implementation roadmap on 2025 to 2027 integrated dashboard are brought online and standardized design for stadium medical rooms are finalized. From 2027 to 2029, citywide drills are run with expo dress rehearsal to test end-to-end flow, and 2030 to 2031 expo is operated in real-time measures learned from and refined as we go. And 2032 to 2033, full-scale tournament exercise are conducted across all host cities. And 2034, world-class tournament health operation are delivered safe, seamless, and ready for the world. The risk register and how it's mitigated. The overcrowding and crowd crash detected by live occupancy maps managed with time entry, one-way flow, gated buffers, and surge stewards. The infectious disease will be picked up via syndromic and lab alerts controlled with vaccination policy, rapid testing, isolation rooms, and targeted messaging. The transport incidents concentrated at hubs and match expo peaks, reduced with EMS ring, dedicated corridors, and air evacuation helipads readiness. Our KPIs and success measures are clear. EMS response time stay at or below 8 minutes. More patients are safely triaged to virtual care, reducing pressure on emergencies. Preventable morbidity and mortality remain low, especially during peak period, and for time critical conditions, door to needle time are kept fast and reliable. In conclusion, in Saudi Arabia, the mass gathering model is tested and scalable. Expo 2030 and FIFA World Cup 2034 will build on Hajj successes. Now is the time to invest in people, platform, and partnership. Our commitment is clear. Deliver care that is safe, seamless, and inspiring for the world, for every guest at every venue, every day. Thank you very much.
Thank you, Professor Said, for your talk. Our next guest, the Professor Badur, he will talk about the how to manage bronchial asthma in mass gathering. The floor is yours.
Thank you for the introduction. So good afternoon, everybody. My second lecture today is, or presentation is about the management of asthma. As you know from the background of my specialty in chest medicine, asthma is really one of the common diseases that we see across our community and even globally, that it is the commonest chronic lung disease that affects people of all ages, starting from 1 year up to even 100 years old can develop asthma for the first time. It is, as you know, caused by inflammation and muscles tightening of the airways, which makes it harder to breathe. And the symptoms can include coughing, wheezes, shortness of breath, and chest tightness. This is just a simple definition of it. The prevalence of asthma is, as I told you, very common. That it is was as high as even 20% in some areas of the population. And generally, we quote the prevalence is about 10 to 12%. And that really means a good number of people. Even among us here, 100 attendee, you will find 5 or at least 5 asthmatics among the attendants here. Some of the, as you know, some of the asthmatics may not have symptoms at the present time, but they are asthmatics, and these asthmatics can just get stimulated and can suddenly have symptoms. This prevalence makes it really common among those who attend the events, the social events and the mass gathering events. So if you are in a stadium for sport who are containing 50,000 like people attending there, at least 5,000 of them are asthmatics. And among the Hajj period, where you get about 2 million in one place, at least 200,000 of them are asthmatics. And even here in our daily Haram attendance of Makkah and Medina, you will see a lot of them are asthmatics. So the disease is common, and it is very likely that you will face it in any mass gathering events. And those who are dealing with the emergency departments, that they know every day they meet a lot of asthmatics attending the emergency departments. In mass gathering events, there has been many studies trying to find out what is the presentation of asthmatics in the mass gathering events. And in one, at least one I quote from during the Umrah period, which is in Mecca, it was about 18% of the presentations of ER cases were asthmatics. About around 20% of those who presents to us during the Umrah period were asthmatics. So it is very important for those who are dealing with the mass gathering medicine that they should know how to manage asthma very well and properly, because the chance that you will meet asthma in a difficult situation with your event is very high, as I told you, as high as 20% chance. The usual recommendations actually for all asthmatics, as you know, is that they should have been under control before they try to perform activities or attend social or mass gathering events. And this is what we always aim in asthma clinics, that we try to make sure that asthmatics are under control and they have less likely chance to develop the asthma attack suddenly. And this is, nowadays can be achieved very well in our clinics with the new medications that we have for asthma. And my usual advice to my patients who are asthmatics, that they should be above 20 of what we call as asthma control tests. There is asthma control test, which is available. It is really about, it's like a questionnaire that, as you see there, has 5 questions, and the patient or the individual who's asthmatic will answer the questionnaire, the 5 questions, and for each answer, he will get a score. The full score, which is 5 marks for the question, multiplied by 5, will be equal to 25. So if the individual or the asthmatics actually score 25, it means his asthma is well controlled or actually totally controlled. And this is usually a kind of safe asthmatics that you can send him to any place and you don't worry as long as he continue his medications, because the chance that this asthmatic will develop an acute attack is very small. So during the assessment, which should be done in these patients, if your patient actually scored the 25 or even 20, so the actually score between 20 and 25 means it's a safe score, and this patient is under good control above 20, and you can just advise him to continue his medications and make sure that he took the vaccinations. And then usually these are very safe and they don't have trouble. However, if you see patients who are not well controlled, then the advice is that you have to achieve control before the offense, before Hajj, before Umrah, before attending any major event, that he should seek advice and make sure that he is well controlled with the medications that are available. And as I told you, now we have good medications that we can achieve control in these patients easily. However, if patients are not well controlled, usually I really don't allow my patients, or at least give them the recommendation not to go for these difficult situations, Hajj, Umrah, or attend a major event if his disease is not stable and controlled. Most of them, they will listen and they will take the medications to become controlled. However, as medicine says, always we have difficult patients, or they can still attend these like events without having good control, and then we will meet them with difficulties during the events. We always advise our asthmatic to put asthma label on them, because if they develop the attack suddenly and they are unable to communicate well, people, if they identify them as asthmatics, then the help might come easily without digging more into the history of the patient. We always also recommend protective measures in these patients, masks and others, depending on the severity. Allergy label, as you know, most of the asthma patients, they have allergy to something because they are atopic and they are allergic, and at least one phenotype of asthma. So if they have allergies, they should also try to label that in their medical record. Nowadays, as you know, we have in our national medical record that they can add them to the application of Tawakkalna, that he is in the application of the national system. They can add in their system that they are allergic to medications or whatever. So allergy label is also strongly recommended. And we always try to give them education that if they see even minor symptoms, they should seek help early before they go into more difficult situations. So education is very important part, as you know, of all asthma or all chronic cases, that they should be well educated about the background of their disease, and they should always seek help early. The likelihood that the asthma patient will develop like an acute flare-up and acute exacerbation during major mass gathering events is high, because usually during these events, we have a lot of asthma triggers around. We have poor ventilation in some places. Some of these events include exercise and long walk and distance. And with exhaustion, the asthmatics may start to develop the symptoms. And as you know, in big gathering events. We have a lot of allergens, whether indoor or outdoor, and the chance that these triggers will make an asthma attack are high or is high. So the acute flare-up of asthma is common in major major mass gathering events. Some patients also, they will actually become a major, cause major exhaustion of the medical resources, because if you see more and more asthmatics coming to your small clinic that you made in the events, they might actually cause a lot of trouble to you. So we always have to be prepared for asthma cases in any mass gathering events, so that we know how to handle them and how to triage these cases. When we speak about the exacerbation and the acute asthma attack, we know that we have 5 degrees of severity of these cases. It can be just mild, can be moderate, severe, or acute life-threatening attack. And as a healthcare provider, we always should be able to differentiate between the mild, moderate, severe, and the life-threatening attack. If we go through the symptoms, the mild attack is usually having some symptoms with some cough. Your patient will start feeling more and more shortness of breath and rapid respirations. However, the patient will be able to speak, drink, and they don't usually have oxygen desaturation in the mild attack. So the patient will just look like he's more exhausted with higher respiratory rate, no cyanosis, and mild cough and more wheezes than usual. This is usually a mild attack. And this is the most common that we see in asthma, the mild attacks. The management of these patients is not difficult, because usually they don't need a lot of observation. If they have been well educated, the rescue medications should have been with them. And usually they will use more rescue medications, which are the rapid onset beta agonists. And we know the salbutamol and formoterol as the 2 famous rapid onset beta agonists. So the patient should have, or the individual who is asthmatic, should have these medications with him if he is well educated, and he can use more and more doses to make sure that he will have better relief. How often the doses he can take? He can take like actually 2 inhalations of salbutamol or even formoterol every 30 minutes till he gets better relief. Or if he does not get relieved and get worse, then he will move towards moderate attack. The moderate attack, the patient will have more shortness of breath. However, he can still walk, and he does not have problem with exercise. Wheezes might be more loud, and the cough might be more persistent. Again, the patient will have no hypoxemia and no cyanosis, and stable from other hemodynamics. Even the tachycardia will not be high, will not be more than 120. And this is just more exaggeration of the mild attack. And in this case, it is very important, actually all cases, but actually the moderate. Once you start to see a moderate attack, the history is very important, and the background. Because if the patient is telling you that usually with these attacks he will get worse, then you should be careful. The background of the patient, whether he had previous acute life-threatening attacks or has been in the ICU before will make you more careful. And the immediate action should be there with more and more short-acting, rapid-acting beta agonists. In the moderate attacks, it is advisable to add LAMA, more like bronchodilators, not only the SABA. And also, nowadays, it is recommended even to get more inhaled ICS, which is the inhaled corticosteroids, in the moderate inhaled. Still, we are in the inhaled, whether DBI, powder, or whether MDI, whether with the patient or can be available in, should be available in all emergency rooms. These medications, the LAMA and ICS inhaled, so that we can add to these patients if they are in the moderate attack. And then we watch the response and progression. Usually they start to have, if they will respond, the responders, they will start to have relief within an hour or so. And then we have to just give more of these medications again. And usually the patient will be in a good position. So mild, moderate, if you are careful and you catch the patient early and you have these medications on board, the chance that you are going to reverse the patient back from the attack to a stable phase is good. However, again, some patients may progress, may not respond, and they may go into the severe attack. Once we label severe, then we start to see hypoxemia. The severe attack that differentiates severe from mild and moderate is that you will start to see hypoxemia. When you put them on pulse oximetry, then they are less than 90% saturation on room air, or they may actually show cyanosis. So if you see these two signs, cyanosis in an asthmatics or desaturation, you are now heading into the severe attack, where usually in this case, you will need parenteral therapy. In addition to your inhaled therapy, whether by powder, by MDI, or by nebulizer, you will need usually in the severe case parenteral therapy. And the parenteral therapy that we usually advise to be given as soon as possible are the systemic steroids. And you can choose what systemic steroids depending on your availability, whether it is hydrocortisone or whether you will use methylprednisolone. Hydrocortisone is more rapid, but it has more mineralocorticoid effect. So it depends on other comorbidities. If the patient has diabetes, if the patient has hypertension, then you may adjust your systemic steroids according to the comorbidities that these patients have. But usually we will need systemic immediate. Once you see cyanosis and desaturation, immediately don't hesitate to give the parenteral IV steroids. In addition to what we have mentioned, the short-acting beta agonists, LAMA, and inhaled steroids you can add, but don't hesitate to give the systemic steroids as soon as possible. If you don't have the parenteral systemic steroids, you can still use tablets orally, a tablet or syrup in proper dose according to the patient weight and comorbidities. But the parenteral is more advisable to be given as IV because it will act as quick. The oral can also actually perform the job if you are lacking the parenteral therapy, but usually I hope that you don't, and you have these parenteral IV steroids. As you know, all the emergency rooms should have them for any acute allergic reaction, including asthma. Most of these patients, if you give the systemic steroids and high doses inhaled therapy, they will respond within 2 hours or so, that you will start to see response. And almost a lot of patients will refer quickly and they start to like having less distress, and the cyanosis will disappear. The respiratory failure signs will start to disappear, and you can have a good success story. However, the problem always there when you see the life-threatening attack. Some patients may just suddenly develop the life-threatening attack, and we call it life-threatening because usually the patient may lose his, not usually, I hope not, but I mean, there is a high chance that the patient may lose his life, or he will go to ICU needing mechanical ventilation in the life-threatening attack. The life-threatening attack is in addition to the hypoxemia and the severe respiratory distress. These patients will start to have disturbed level of consciousness and poor hemodynamics. So if you start to see these signs, the poor hemodynamics, whether high blood pressure or low blood pressure, pulsus paradoxus, I hope you know what is pulsus paradoxus, which is a problem with the blood pressure inhalation and exhalation. So once you start changes in hemodynamics, and once you start to see disturbed level of consciousness with asthma attack, then you are at the last spectrum of severity, which is the acute life-threatening attack. These cases, usually, once you see it, you have to be, again, very careful, and you have to put the patient under very, very close monitoring, and you start all the medications that I mentioned of bronchodilators. Usually we need 2 bronchodilators, LAMA and SABA, in addition to inhaled steroids and in addition to IV or parenteral steroids. Some patients may need, as you know, we were using the subcutaneous adrenaline because it can have quick effect, but you have to be careful with using these adrenaline in these patients. Make sure that they don't have comorbidities, coronary artery disease, arrhythmias. So we usually don't advise to use adrenaline unless the patient has background already of severe atopic attacks in the past, which was saved by adrenaline. Usually we give it, the recommendation is to give sub-Q. However, most of the cases you can manage with the more and more beta agonists and more steroids, or even IV aminophylline. Usually these patients will not be discharged, and usually these patients, you should decide admission from the minute 1, because even if they reverse the acute life-threatening attack, they have to be kept at least 24 hours in the hospital or in the area before you can let them go home. Once you see signs of acute life-threatening attack, disturbed hemodynamics and disturbed level of consciousness in acute asthma attack, then you will decide admission immediately from the first minute. While you are preparing the management, you have to book a bed. The question will be an ICU bed or a usual bed, depending on the response. But you don't discharge patients with acute life-threatening attack immediately, even if they reverse back to even normal. You have to observe them for some time in the area, in the emergency room. Usually admission is recommended. So these are the attacks that we see in asthma patients. And actually they are actually life-threatening. They can be life-threatening, and all emergency departments and people who are working with asthma gathering events should be aware of these attacks. They should be able to diagnose them immediately, whether from the history or from the scene. And the action plan should be immediate because they can deteriorate within minutes. So this is what I can just quickly, in the time that I was given to me, to conclude that asthma is common. The pre-event assessment and education is very important, and always we have to educate our asthmatics to seek the assessment before they go, if they plan the attendance of this major event. We should provide them with good education and the vaccination before the event. Once you see an asthmatic, you should decide the level of severity that you are dealing with, and you have to monitor response. In patients, once you decide, then the action should be immediate, and the patient should be observed for response or for worsening. And alhamdulillah, most of our patients, as I told you, they present in mild and moderate cases, and they can be reversed with good management within 1 hour or 2, and they can go back home to seek their outpatient follow-up. However, some patients, as I told you, will need more and more careful issues, and some they may just suddenly go into cardiac arrest if you delay the management or if you don't give proper treatment. So I hope that this will finish my task in this regard. Asthma is one of the commonest diseases, and we should be careful. Thank you for listening, and I think the questions will be later.
Thank you, Professor Badr, for your kind and wonderful presentation. Our next speaker is Dr. Khalid Ghuleili. He's an ID consultant from King Salman Medical City. He's the head of the ID department in King Salman Medical City here in Al-Madinah Al-Munawwara. He will present today, inshallah, respiratory tract infection, mitigation in how to mitigate and how to do surveillance in high crowd intensity situation. Thank you, Doctor.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I want to thank the organizing committee for their kind invitation. And also I want to welcome all of you in the third international symposium of mass gathering and emergency medicine. I will share with you some information about the respiratory tract infection surveillance and mitigation in high density environments. The key point we'll speak about high density setting, increase the risk of respiratory tract infection transmission due to overcrowding, poor ventilation, and social behaviors. Surveillance include clinical data, real-time aerosol and wastewater monitoring, enhancing early detection. Environment factors like temperature, humidity, and urban design also affect the risk of transmission of respiratory tract infection. Medication strategies, vaccination, masking, hygiene, improved ventilation and air filtration, early testing and isolation reduced the transmission of respiratory tract infection. Integrated surveillance and mitigation are critical to protect the vulnerable population in crowded environments. Mass gathering and international travel facilitate respiratory pathogen spread globally, like Hajj, like Olympic, like sport and music event. This due to crowding, close contact, and mixing diverse population that increase the risk of transmission of respiratory tract infection. High population density facilitate respiratory tract infection spread, like hospital, school, transport hubs, and also mass gathering. Mass gathering and transitory facilitate respiratory pathogen spread globally. And I repeat this slide again. A major respiratory pathogen at mass gathering is influenza, rhinovirus, coronavirus, respiratory syncytial virus, and bacterial pathogen like strep, pneumonia, and Haemophilus influenza. There is a document that influenza outbreak occur in Hajj and Olympic and youth events, and multiple strain leading increasing in the resistant virus, and there is increased attack rate if gathering occur near pandemic. There is specific pathogen example post. There is a study done in the France pilgrims, French pilgrims during 2016, and they found that they did for them screening pre-Hajj and post-Hajj, and they found a significant increase of post-Hajj positivity of rhinovirus, coronavirus, and influenza virus, and Haemophilus influenza, and streptococcal pneumonia. And many of these returning pilgrims remain asymptomatic, and that emphasizes the need for post-travel screening and health measures. The mechanism of respiratory tract infection in mass gathering and travel: crowding increase the droplet aerosol exposure, poor ventilation and poor contact elevate the transmission risk, and global attendee mobility lead to pathogen exportation. Factor affecting respiratory tract infection transmission: density, ventilation, behavior, weather affect the spread also. Well-ventilated spaces reduce the airborne transmission risk. Both environmental and human factor shape the infection dynamics, and intervention must target these elements. Surveillance of respiratory tract infection in high-density setting include airborne viruses. Monitoring is essential for early detection of respiratory infection in crowded environment. There is a novel high-sensitivity aerosol monitoring system like real-time aerosol virus monitoring can detect SARS-CoV influenza and respiratory syncytial virus. Aerosol sampling provide more accurate assessment of infection risks compared to traditional surface swabs. Also, surveillance can detect which respiratory virus are circulating and identify emerging strains. This helps to monitor the change in virus type and their spread pattern. For example, Canada integrate respiratory virus surveillance track influenza virus and respiratory syncytial virus and SARS-CoV virus to understand the seasonal trend and detect any new variant early. Also, to help us in the public health response and control. Data from surveillance guide decisions such a vaccination program, travel advisor, infection control measure. Also, surveillance provide evidence to target intervention effectively. For example, the WHO Mosaic respiratory surveillance framework use the multi-source data to inform coordinated public health action globally. Also, surveillance can also protect global public health. Early detection from surveillance system enable rapid response to outbreak or pandemic, minimize the illness and death. The US National Respiratory and Enteric Virus Surveillance System provide weekly data that support timely outbreak declaration and public awareness campaigns. Challenge of surveillance respiratory tract infection. Technical challenges and in virus collection. Viruses are much smaller and lighter than bacteria and fungi, making airborne collection technically difficult. Aerosolized viruses can be below detection limit if sampling method are not sensitive enough. Another challenge is interpretation of the result. Detecting a virus in the air by PCR or antigen test doesn't necessarily mean the virus is viable or infective. Many viruses particle may be non-viable due to factors like drying or ultraviolet exposure. Only viable virus can be infectious. And there should be a linking airborne viruses to clinical infection. Air sample must be interpreted with clinical data and epidemiological data to understand the exposure risk and actual transmission. For example, there is a study that is conduct extended air and mucus sampling in child care setting to correlate airborne virus with infection in attendees. Also, one of the challenges is healthcare seeking behavior and resource variability. Surveillance can be limited by difference in healthcare access, diagnostic resource, and specimen collection and specimen collection quality across the region. And this affect the representative and the reliability of surveillance data. We'll speak now about mitigation strategies. Mitigation strategies are proactive measures designed to reduce the likelihood and impact of respiratory tract infection in population, focusing on interrupting the transmission and protecting vulnerable individuals. Mitigation require a multi-layered approach combining vaccination, personal protective behavior, environmental control, and promote infection management. One of the strategies is vaccination campaign to target a major respiratory virus such as influenza, RSV, and also SARS-CoV. Benefit of vaccination for individual and community immunity, and also there should be a strategy to improve vaccine uptake and coverage in the community. Vaccination challenges and solution. Overcoming vaccination hesitancy and misinformation. There should be equity in vaccine access, and there is also should be a public education to public education and also health care provider engagement. And we should have strategy to enhance hygiene measures like hand hygiene, respiratory etiquette, cleaning of frequently touched surface, and impact of virus transmission. Masking policy, mask type, and effective like cloth surgical or 95, when should be used, and also how to use mask, use indoor or in crowded setting, and also to share with them the evidence for reducing respiratory virus transmission. Infrastructure improvement, improving of ventilation and air filtration, indoor spaces as classroom, and also workplace, remove the airborne virus particle, and also use of HEPA filter, and increasing fresh air exchange is critical for reducing respiratory tract infection in high density setting. Also, one of the strategies, the early case identification and isolation. We should have a rapid testing availability and use like antigen or PCR, and also we should have contact tracing and quarantine protocol, and we should have a support policies like sick leave and remote work. In conclusion, continuous surveillance and adaptation is critical. Encourage community participation and compliance, and also we should have integrated mitigation approach is essential for control. And thank you very much. Thank you.
Thank you, Dr. Khalid, for your presentation. Our next speaker is Dr. Abdulaziz Silan. He's an ID consultant from King Salman Medical City. He's also the chairman of stewardship committee in the same hospital. He will talk about the infectious biohazard in mass gathering situations.
Assalamu alaikum. First of all, I think I'm the youngest speaker today, so I will thank the scientific committee for this opportunity, and I hope this presentation will be useful. So my talk today will talk about infectious biohazard agents, preparedness, risk, and response strategies. My objectives in this talk, we will define what constitutes an infectious biohazard in the context of mass gathering, and we would identify common and emerging infectious agent that poses risk during mass event, and recognize the high risk setting and behavior that facilitate transmission, and understand the core components of biohazard preparedness and response, and review case studies and lessons learned from previous global events. So biological hazards are disease-producing agents that can be transmitted to individuals through various routes of exposure, and exposure to these hazards may result in acute or chronic health conditions. Types of biological hazards, we have biological agents, which include organisms, including bacteria, viruses, fungi, and protozoa. We have biological toxin and venoms. Those are substances poisonous to human and other organisms produced by different types, for example, bacteria, fungi, protozoa, reptiles, fish, mollusks, insects, and plants. Blood and blood product, environmental specimen, these could be plants, soil, or water that are likely to contain biological agents or toxins. And to understand these biological agents, we should identify or we should know the risk group classification of biological agents. We have 4 risk groups, group 1, 2, 3, and 4. Group 1, those biological agents that have potential, unlikely to have potential to cause disease to a human, and it has low hazard degree to workers, and unlikely to spread in community, and effective treatment or preventive measures are available, while group 2 has likely but minimal potential to become serious hazard, and hazard degree to worker intermediate, unlikely to spread to community, and the effective treatment or preventive measures are commonly available, while group 3 likely to cause serious diseases, but treatment or measures may be present, and those group has possible serious degree to workers and possible to spread in community, and the effective treatment or preventive measures are commonly available. While group 4, those biological agents or hazard are likely to cause serious diseases, but treatment or measures may not be present, and it carry a serious risk to hazard degree risk to workers, and the spread to community is likely, and finally, the effective treatment or preventive measures are usually unavailable. To have an example of these biological agents, Legionella multifilia, Legionella species, Salmonella, E. coli, with the exception of non-pathogenic strains, Varicella zoster causing chickenpox, shingles, influenza viruses type A, B, C causes flu, all are group 2, while Bacillus anthrax, E. coli, which is the very cytotoxic strain of E. coli, Salmonella typhi causing typhoid fever, SARS-related coronaviruses, COVID-19, all are group 3, and Ebola virus, Kariman Congo hemorrhagic fever are group 4. To understand these biological agents, we should understand the chain of infection. So we have a microorganism like bacteria, viruses, fungi, or parasite. Those microorganisms need a reservoir, which is habitat for organism to grow. After being inside this reservoir, it needs a port of exit like secretions or, for example, saliva or excretion. And then they need a mode of transmission either by contact, droplet, airborne, and then a port of entry by mucosal lining or open wounds, oral, respiratory tract, or urinary tract, and then a susceptible host like very young, elderly, and those with chronic diseases or immunocompromised patients. So why mass gathering are at high risk for infectious biohazards? One of the major public health concerns and related to mass gathering event is the importation or exportation of the infectious diseases and the spread between attendees to local population. Planning, global communication, public health surveillance, and response at mass gathering help to avoid the threat to global health security posed by infectious diseases that might be exposed to home country. Some of the factors like urban expansion and land use change lead to novel human-wildfire interactions. Air pollution increased the disease susceptibility, more persistent outbreaks of respiratory diseases in urban setting, poor sanitation and high population density increase the spread of enteric infections, and global transit network increase the risk of importation and exporting pathogens. Other factors like increased worldwide transport, migration, and relocation of animals and food products, change in food processing, handling, and architecture practices, and change in human behavior, technology, and industry. Some of the examples of the infectious biohazard agent, we have bacteria, viruses, and parasites. Example for bacteria like Salmonella, Shigella, Vibrio, Neisseria meningitidis, those can be transmitted by food, water, or close contact. Symptoms like food poisoning, diarrhea, or meningitis can present in outbreak, and preventive measure and control, including safe food, water hygiene, and vaccination in cases of meningitis. Viruses like influenza, COVID-19, MERS, hepatitis, and measles, those can be transmitted by airborne droplet contact, contaminated water, or food. Symptoms like respiratory illness, hepatitis, skin rash, and measles outbreak can present. And vaccination, mask, hand hygiene, and surveillance is the preventive and measure control. Parasites like Giardia, Entamoeba, Cryptosporidium, Cyclospora, lice, scabies, those can be transmitted by contaminated food and water, skin contact, shared clothes. Symptoms like diarrhea, dysentery, itching, skin lesion, like in case of scabies or lice outbreak, and the preventive and control measure like safe food, water, sanitation, hygiene, prompt treatment, all and reduce overcrowding, all are preventive and control measures. And to facilitate the identification of the types of threat most likely to occur at mass gathering, we should answer the two questions. Question one, what outbreaks or increase in transmission of any infectious diseases have been observed during and within 2 weeks of mass gathering events linked to mass gathering or linked to mass gathering event in the past 10 years? And question two, among the studies including what preparedness and response measures were implemented in countries by public health authority, Ministry of Health and event organizing committees before and in response to potential outbreak during mass gathering event. And just to go back the history of outbreaks in the last 2 decades, as we can see here, there are some of diseases causing epidemic outbreak and other diseases were causing pandemic. The four most pandemic that happened during the last 2 decades is SARS-CoV in 2002 and 2003, which with a case fatality rate of 10%, swine flu in 2009, 2010, influenza H1N1 with a case fatality rate range from 2.9 to 9.1%, and MERS-CoV from 2012 to 2019, Middle East respiratory coronaviruses with case fatality rate of 34.4%. And the last pandemic was COVID-19 with a case fatality rate from 0.1% to 15.2%. So what is the risk management consideration? Before preparing for any mass gathering, we should identify the risk related to population, visitors, and environmental factors. We should evaluate, plan, and prioritize healthcare needs for mass gathering, mass casualty preparedness, and we have to assess communicable diseases risk and plan for outbreak response. We have to have food and water safety and hygiene recommendations, identify security risk, including acts of violence and terrorism, assess local risk, and prepare and response to natural hazard, crowd safety, and finally, prepare for and provide post-disaster mental health care. Just reviewing to the literature from 2004 to 2024, from the mass gathering event that happened during this period. For example, in Olympic and Paralympic Games, there are some 12 articles there was published reporting some outbreak like respiratory diseases, SARS-CoV-2 and GI infections, while in other mass gathering, there is, like in Football League and rugby, there is also outbreak of SARS-CoV and botulism. In other festivals and mass gathering, also there are reported outbreak of COVID-19. So as we can see, the most outbreak are coming from respiratory diseases or diseases that can be transmitted by droplet precaution or through respiratory route. Other events like festivals, which was done in Europe, Japan, Portuguese, and USA, there are some outbreak, including acute gastroenteritis, measles outbreak, invasive meningococcal and mpox. Fairs and convention, there are also outbreak of SARS-CoV-19, swine flu, and H1N1, and several other events showed some outbreak of swine influenza, measles, and GI infections and mumps. An important note is that it can be difficult to determine if an outbreak that takes place in a temporal association with a mass gathering would have occurred if gathering had not taken place. So what are the considerations for public health authorities preparation? We should commence all hazard preparedness planning at an early stage and involve public health sector from beginning. It's crucial to work with other sectors throughout planning phase, carry out national risk assessment on infectious disease threat early on to enable the capacity for early detection and response to be mapped, enhance existing surveillance system and capacity at different levels. Multiple layers of system are required to provide an overview of involving situation or threat and facilitate risk communication. Other consideration, we have to view organized mass gathering events as good opportunity to arrange health promotion activities, prepare risk communication, community engagement, and infodemic management activities ahead of mass gathering. Participants should ideally receive information before, during, and after such events. Several areas of advice should be considered, from simple hygiene rule to recommend immunization, appropriate protection from extreme weather condition, how and where to seek medical help, organize lesson learned activity after the event to facilitate changes to preparedness plans and to assist other country planning for future events. So we'll talk about Hajj as an example of mass gathering. The key factor that we have an annual Hajj is annual Islamic pilgrim to Mecca, coming to Mecca in Saudi Arabia, 2 to 3 million pilgrim from 180 countries, high density gathering, especially in Tawaf and in Arafat, and public health challenge in mass gathering. There is an increased risk of disease transmission. What are the epidemiological triad in the setting of Hajj? We have host factor, agent factors, and environmental factors. Host factor like age, immunity, vaccination status. Agent factors, viral versus bacterial pathogen. Environmental factors, including crowding, sanitation, and climate. The key epidemiological factors, which include high population density, which lead to rapid disease spread, international travel, which lead to importation of pathogens, climate, heat, humidity, favors pathogen survival, shared accommodation, increase the respiratory and GI infections, pre-existing condition in pilgrim like diabetes and elderly, which can be, or those can be higher susceptible patient to have an infectious disease. So international travel and global diseases importation, pilgrim come from over 180 countries with some with endemic diseases, for example, malaria, dengue, and polio, risk of emerging or re-emerging infectious, MERS-CoV, cholera, and Zika. Asymptomatic carriers may introduce pathogens, for example, meningococcal meningitis. What is the history of diseases outbreak in Hajj? As we can see in the past, the most predominant disease were cholera from 632 and up to 1892. With improvement of sanitation, it moved from the cholera toward meningitis and reported meningitis outbreak during Hajj. What are the lessons learned? In the year of 1987, there was a meningococcal meningitis outbreak with the pathogen Neisseria meningitis group A, which caused more than 2,000 cases and 400 deaths. The key factors were crowding, lack of vaccination, and the public health response was first introduction of meningitis vaccine mandates, and the lesson learned was highlighted the need of pre-Hajj immunization. In 2000, meningococcal meningitis outbreak with the serotype W135, more than 1,000 of cases. The key factor was vaccine gaps in pilgrims, and the public health response at that time was applying of quadrivalent ACWY vaccine mandate in 2002. And the lesson learned that cases were dropped by more than 90% post mandates. And in 2012, MERS-CoV threat with pathogen MERS coronaviruses, no Hajj-linked cases. The key factor was its zoonotic diseases transmitted by camels through respiratory or contact. The public health response were enhanced screening, camel contact warning, and the outcome and lesson learned was improved surveillance prevents outbreak. In 2013, scabies outbreak in Minatins with pathogen scabies mite, 200 of cases, and the key factor was crowded living condition and close contact. The public health response was enhanced surveillance, active case finding, isolating suspected cases, and the outcome or the lesson learned that we learned that rapid decline in new cases, demonstrating the effectiveness of early detection, standardized treatment, isolation, and health education in controlling of the outbreak. In 2016, norovirus gastroenteritis with the pathogen norovirus, more than 2,000 of cases. The key factor was contaminated food or water. Public health response was hygiene campaign and mass sanitation. And the lesson learned that reinforced hand washing and food safety protocol can prevent transmission. And in 2020 and 2021, the COVID-19 SARS-CoV-2 cases in 2020, the response in 2020 that Hajj was restricted to 1,000 of local population. The key factor was pandemic airborne spread at the initial time of the diseases. Public health response was first cancellation of Hajj, and the outcome or lesson learned that extreme measures are necessary in some pandemic. In 2021, the Hajj was restricted to 60,000 of attendee. The key factor was vaccination and PCR testing, including the public health response was by applying digital health, basis thermal screening, and the lesson learned was combination of vaccine plus testing works. So what are the diseases have major impact on Hajj? Influenza, upper respiratory tract, tuberculosis, pneumonia, bronchitis, pertussis, SARS, MERS-CoV-2, and COVID-19. Those are the most important, while other like meningitis, measles, mumps, diphtheria can take place. And what are the diseases under active surveillance on Hajj and why should be monitored? Meningococcal meningitis mandatory vaccine now is provided because of history of outbreaks. MERS-CoV-2 because it's endemic in our region. COVID-19 with the recent pandemic carry a risk of respiratory tract transmission. Cholera risk from endemic countries, which is a waterborne risk. Influenza, international travels and seasonal flu. Polio, it's a emergence in some countries. Gastroenteritis, diarrhea, which is food and water, which has because of food and water hygiene issues. Measles, rubella, dengue, and etc. based on the origin country of pilgrims. So what are the Hajj authority response and planning strategy? Advanced planning, health education and awareness campaigns, water and food supply alongside safe sanitation, pre and post travel advice and vaccination opportunities, control at port of entry, clinic and hospital care integration, information technology and surveillance. So what are the challenges in preventing infectious diseases spread in mass gathering? First is close contact. Close contact cause easier spread of airborne and droplet infections, including flu, COVID-19, and tuberculosis. Poor ventilations promote airborne disease transmission. Shared toilet and eating areas carry a risk of fecal oral transmission of hepatitis and cholera. Overwhelmed healthcare access lead to delay in diagnosis and treatment. Limited hygiene resources lead to inadequate soap, water, or PPE supplies. Presence of vulnerable individuals, for example, elderly, immunocompromised, are at high risk. So what are the challenges in our country? Many countries, in our region, many countries are still poorly prepared to detect and respond to outbreak and epidemic. Infectious disease outbreaks have consistently been reported from various countries in the region during the last few decades, and most have been detected late, resulting in delays in outbreak response. The surveillance system in most countries remain fragmented and paper-based, with a variable and limited ability to detect impending health threats in real time. Many countries do not have adequate laboratory capacity for detecting or diagnosing emerging or new pathogens, or for identifying novel influenza viruses. Collaboration between animals and human health sector is weak. Other challenge, like several countries in the region have included additional vaccine in their routine immunization programs. However, information on the population coverage of these vaccines is not available, and therefore their effectiveness or impact on controlling the emerging pathogen have not been studied. Vaccine coverage is low in countries, particularly among vulnerable groups and other groups at high risk. So in conclusion, mass gatherings are at their best a representation of humanity coming together and celebrating the social force of shared experience. As experience are accumulated, the balance of risk versus benefit can be shifted toward the safe, successful hosting of mass gathering, the need of national and international level, focusing on early detection, response, and strategic planning for preventing major infectious threat. And in mass gathering, even the ordinary can become extraordinary. And final message, the goal is not to stop gathering, but to make them safer through preparedness, focusing on early detection, response, and strategic planning. And thank you.
Thank you, Dr. Abdulaziz, for your nice presentation. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. I will introduce myself. Okay. My name is Ahmed Al-Ghabban. I'm an assistant professor of emergency medicine and disaster medicine and emergency medical service. First of all, thank you for being here for the last session today. Second of all, I would like to extend my sincere thanks to the organizing committee, especially Dr. Al-Fifi, for putting this together for the third time in a row. My today topic is actually quite big, but I did my best to summarize it as much as I can. And there is a lot of debate around the ethics in mass gathering and in disaster medicine overall. Today, I will dissect the core ethical conflict through 6 critical challenges. But first, we'll define what is the mass gathering. The WHO definition of mass gathering is a planned or spontaneous event where the number of people attending is sufficient to strain the planning and the response resource of the community, state, or a nation having this event. The key difference between it and between the disaster medicine, or disaster in general, disaster are reactive events, while the mass gathering medicine are proactive with planning. But keeping in mind that, as we can know, a disaster can happen inside a mass gathering. And sometimes a planned event turn into disaster in minutes, as we know. Think about a stampede during a religion event like in Al-Hajj, or in a stage collapse during a concert. In this moment, we have moved from planned, well-organized care to what we call crisis standard of care, meaning that we have to make a tough choice about who gets what resource, and this situation also put our staff in higher personal risk. Why ethics in mass gathering? Mass gathering presents a unique challenge. Unlike routine medicine, resource may be scant, patient numbers are overwhelming, and decision-making must be rapid. Patient autonomy is often restricted, raising issue of justice and fairness. Ethical decision made in such environment also directly affecting public trust, which is essential for effective response, as we will see in the next, inshallah, few slides. There is a foundation for moral duty in mass gathering. We have four foundations that we have to know. The first one, duty to care. Healthcare provider in mass gathering operate under the moral obligation to treat those in need, even in challenging or hazard situation. This duty is balanced by the need to keep responders safe through training, proper equipment, and rest period. Duty to prevent harm. Prevention involves anticipating hazard like heat illness, crowd surge, or infrastructure failure, and implementing measures to minimize them. The third one, duty to fairness, is crucial to maintain public trust, ensuring that all attendees, whether VIPs or ordinary visitors, receive equal care. And finally, duty to respect. Individual means acknowledging and accommodating culture and religious needs, protecting privacy and maintain dignity in all care. These duties are equally relevant in disaster scenario where urgency and chaos test the commitment to these four values. There is a four ethical framework we have to balance between them. The first one called the utilitarianism or النفعية. This one, that means in high pressure environment, utilitarianism focus on the greatest good, often influencing triage priority, as we will discuss. The second one is the egalitarianism, المساواتية, ensures equitable care and prioritizing vulnerable populations such as the elderly or the disabled. Procedural justice, what's called the العدالة الإجرائية, demands transparent and consistent decision-making supported by predefined protocol before the mass gathering event. And finally, the pragmatism or pragmatia. It's mean acknowledge that during emergency, decision must be made quickly and sometimes with incomplete information. But transparency and post-event review help maintain accountability. For the first ethical challenge that we'll discuss today, the crisis standard of care. Normal standard become impossible when demand increase more than resource, like in a pandemic, stampede, or earthquake. The focus shift from from perfection for individual to maximize benefit for the whole population. And this guarded by four principles: fairness, transparency, consistency, and accountability. What to change under the crisis standard of care? There is a reduced resource investment per patient, prioritizing based on survivability and overall benefits, and use of stockpiles, volunteers, alternative sites, adaptation and reuse of certain items like PPE or ventilator parts to stretch our resource. What is never changed under crisis standard of care? Respect of dignity and human rights, fairness and non-discrimination, and finally, providing palliative care and comfort for those not expected to survive. Ethical challenge number 2, triage in the crowd. The core ethical principle behind the triage is what is called distributive justice. What does that mean? the fair, equitable, and appropriate distribution of benefits, risk, and cost within a society or a group. In mass gathering medicine, it is the primary principle overriding routine medical ethics. And the governing framework, as we said, the utilitarian or utilitarianism. The core idea that is the most ethical choice is the one that produces the greatest good for the greatest number of people. The practical application of this, as we know, the triage system, as it is inherently utilitarian approach for the triage system. And there is a debate between two groups, the utilitarian groups and the egalitarian groups. The utilitarian argument that prioritizing patients who require minimal intervention to achieve maximal benefit. On the other hand, the egalitarian argument that every human life has equal intrinsic value. A lottery system or first came, first served is the only truly fair method in triage. Who's worth more resource, as we said? But what about the vulnerable population? Does a utilitarian approach unfairly those who are more frail to have pre-existing condition? Should the 20 years old be prioritized over a 70 years old within the same injury? Because of that, triage protocol often avoid explicit age-based criteria due to this ethical dilemma. So what is the answer? Is the procedural justice. The most ethical process may be more important than the theoretically or perfect outcome. Any triage system is ethically defendable if it is contain all these four criteria. Applied uniformly to all patients, based on the best available medical evidence, transparent in its principles, and finally, flexible and responsive to changing of resource level. What about the expected category or black category? What does mean black category? And for the triage and the triage level, inshallah, tomorrow, our colleague, Dr. Abdurrahman Al-Jaid, he will talk extensively about the triage method and which triage we will use in which situation, inshallah. What is mean by black category? Patients with injury that are so severe that they are deemed unsalvageable given the current overwhelmed resource constraint. For example, unsurvivable traumatic brain injury or high-grade burn over 90% of the body surface area. The ethical dilemma here, this decision feels like betrayal of the clinician duty to never abandon a patient. But actually, it is justified by ethical duty of resource stewardship, using limited personnel, time, and equipment on those who have a chance of survival. And actually doing nothing is truly doing nothing, is not truly doing nothing. When a medical staff decide not to treat one patient, that decision is an active choice. That means it is free up limits like a resource, a time, and personnel that can be directed toward other patients who have higher chance of survival. What is the physiological impact of that? Making this classification inflict severe moral injury on healthcare providers who are trained to fight for every single life. And how to mitigate this? By doing a strategy or protocols. Must be include provision for comfort care for expected patients. They are not abandoned. Their care of goal is shifted from curative to only palliative care. And the triage is a dynamic process. That means triage is not one-time event. It is a dynamic, continuous process. As a resource become available or the scenes become more secure, a patient triage category must be changed. As I said, the initial expected or black decision is context dependent, and failure to reassess is moral failure. To ignore reassessment in triage is to choose neglect over a care. The operational challenge for doing that, I mean the retriage, this requires dedicated personnel, what is called triage officer, whose sole job is to manage the flow and constantly reevaluate patient waiting for care or transport. It is a massive logistic and ethical challenges. The most important topic, I think, today is the ethical challenge number 3, triage and how to treat, how to manage a VIB personnel in that event. In the triage, medical need is the solely determined. A patient's fame, wealth, or power must not influence triage category or priority. Status doesn't mean medical priority. Why it is matter? Deviating from this principle violate the distributive justice rule that we talked about the previous slide, erodes team morale and trust in leadership, and leads to loss of credibility for the community. What we will do for the VIB patients? As we said, for medical care, it is only one standard. The category is only determined by clinical need and survivability only. VIB are treated within the same medical system by the same protocols. And for logistic and evacuation and private channels, they should use their own private assets. VIB must use their own private security, transportation, and logistic if available. And we have to do what is called dual corridor. There is a medical evacuation corridor for the public, and VIB and private logistic corridor that are separated roads for private assets and must be pre-planned to prevent obstruction of medical corridors and overall crowd flow. And finally, that transparency. Fairness must be visible to other patients, the public, and the responding agency to that mass gathering to maintain trust and operational integrity. What about if we lose a leader? The dilemma is loss of leader may destabilize community, as we know. This is one of the most difficult ethical dilemma in mass gathering. From utilitarian perspective, protecting the life of a leader may have indirect benefit. Losing such a figure could destabilize the community, reduce trust in authority, or even cause widespread unrest. However, favorism based only on social status violates the principle of fairness and transparency and equal respect that we talk about it. If the public sees the VIB receiving unfair medical preference, it can erode trust and actually worsen the instability. So, what is the middle ground? How to solve it? As we said in the previous slide, if the VIB have already their own resource, they should use or integrate it to the system so they don't drain public medical resource. Security planning for VIB movement must not block the medical evacuation corridor for ordinary visitor. And most importantly, as we said, the visible fairness is better than hiding privilege. People are more likely to accept the difficult triage decision if the system appears consistent and transparent and non-discrimination. Ethical challenge number 4, the safer rule. I mean the respond worker prioritization. Unlike the VIB, respond worker like the AMS, the physician, the nurses, or the security may receive priority in triage or prophylaxis. The ethical justification of that, they are, if responders stay alive and functional, the whole population will benefit from them. They are at higher risk than general public. Prioritization motivates them to stay and serve under dangerous conditions. And it is a form of social gratitude to them. But it must be done transparently. Otherwise, the public may see it as a special treatment for our crew. Bottom line, prioritize responder if it is increased survival for the many, but don't prioritize VIB just for their status. How to ethically apply this in our situation or in our mass gathering in our protocol. First, we have to definition who's the responder, who's qualified to be called responder, like the medical team, security, and critical infrastructure like the engineering. They are restoring the power or water communication technician if we have. It doesn't automatically include administrative staff or off-duty personnel not assigned for that day or family members of the responder. Second, ensure transparency and communication. This policy must be publicly justified before an incident occurs and communicated during a response. And finally, integrate it into triage protocol. As we said, there is many triage protocol. There is one called BCI or Bensouskasuk triage system. In this triage, they include a specific B3 provider category for that exact purpose, ensuring it is applied systematically and not randomly. The ethical challenge number 5, informed consent in crisis. In a disaster response, there may not be enough time for informed consent to be a realistic possibility. I quote from the World Medical Association. And as we said in the previous slide, we shift from standard of care to crisis standard of care. That means we change from full autonomy and detailed consent to expedited consent and transparency. The core principle here, when consent is impossible, autonomy is upheld through fair process and clear justification. The practical guidance, we have two entities. There is one interventions not require explicit consent, and the other intervention to require enhanced justification and agreement. The first one, the intervention not require any explicit consent. We can do it without taking permission from the person or from the patient, like triage and resource allocation decision, mandatory public health measures, immediate life-saving intervention for incapacitated patient. For the other one, the example is evacuation decision, significant freedom restriction like physical or chemical restraint for agitated patient, high risk irreversible procedure like amputation or surgical intervention. And in this category, we have three choices or three options. If the patient has capacity, we have to seek assent, or a clear rational refusal, dissent, must be respected. Unless a clear imminent threat to other exists, if this happens, we will change that in this situation will not require explicit consent. If the patient is incapacitated with a proxy, we have to consult the next of kin or the proxy for the judgment. And if the patient is incapacitated and there is no proxy, we will have to act in the patient's best interest. What is the rationale behind the two entities? The justification for the first one, as we said, this is public health and safety action governed by the principle of justice and stewardship. The other one, we have to respect the patient autonomy in all time. As we always say in my lecture, transparency always required. This is how we maintain trust and respect autonomy when we cannot offer other choice. Always explain why. Continuously communicate with the rationale behind the triage and health decision. Disclose the steps and risk for any procedure. Please explain what you are doing and the association risk, even if its time is critical. Debrief afterward. When possible, explain to the lower priority patient why they are experiencing a delay. This acknowledges their suffering and validate their experience. This slide will be a long slide because I will say how to break down this in practice step by step. First of all, some decisions simply didn't require any consent. And the triage is the biggest example. You cannot ask a patient for permission to be tagged red or black. This is a population level decision for the greatest good. Similarly, mandatory isolation or quarantine for a contagious disease is a public health imperative, not an individual choice. Second, for intervention that direct affect the single patient body autonomy, we move from informed consent to informed assent. We lower the bar here. For example, you might say, sir, your leg is crushed and infected. To save your life, we need to remove it. Is that okay? You explain the urgent necessity and get a nod or a verbal yes, or assumes implied consent if the patient are in distress. The key is respect for the person, even if the formal process is abbreviated. Finally, and this is the most important ethical guide, transparency is essential. Even if we couldn't ask, for permission in the moment, we have a duty to explain afterward. For example, you can say, ma'am, you were unconscious. We had to perform a procedure to stop your bleeding. Here's what we did and what happened next. This rebuilt the trust and respect the patient dignity when they are at the most vulnerable state. It is also mean being clear about why decisions were made. So the rule is act first to save life and limb, explain as soon as you can, and always respect the person behind the patient. Our moral duty isn't to the paperwork, it is to people, and that require wise judgment in how we navigate their autonomy when they every second account. The final ethical issue, the privacy and confidentiality. Respect for autonomy is essential linked to the right of privacy and confidentiality. This is a cornerstone of the patient-provider relationship. In mass gathering, the actual environment of the mass gathering, if it is in the field or in the street or the crown tent, makes the traditional privacy a physical impossibility. And the ethical principle collides with operational reality. What is the type of privacy challenge in mass gathering event? There is actually a lot, but I divide it into physical and auditory privacy, open tent, and exam, the risk being overheard or seen. Information privacy, a chart device and hard handover are exposed, this boosting a risk of breaching of patient confidentiality. And actually being seen in certain tent like substance tent or psycho tent relieve sensitive information and leads also to stigma and discrimination or social consequences. And finally, and this is the new reality now, the smartphone can turn private medical crisis into public content within matter of seconds or minutes. What is the ethical and physiological impact of that? Loss of dignity, secondary trauma, chilling effect. What is chilling effect? That means the patient or the spectator fear of exposure may stop people from seeking help. And finally, there is a legal gray zone, and this is hard to control because citizen recording in public are rarely restricted. How to mitigate this? We have to do environmental mitigation, like use of barriers, screen, and vehicle to create privacy zone. A process mitigation. As we said, since privacy cannot be ensured, the ethical goal shifts to harm reduction and respect. As an example, you can say for the patient, I need to ask you some sensitive question. I apologize that we don't have any private room right now, but I will keep my voice down. Please do your best to answer quietly. This demonstrates respect and maintain maintain the support for this patient. Policy mitigation. train staff in dissection, privacy and privacy technique, and enforce non-recording policy for staff and empower leads to address the bystander. Finally, the social media policy, have a clear policy for staff that prohibiting the recording or photographing of patients for non-clinical reasons. Empower a team leads to politely request bystander if it is safe to stop recording. Finally, how to build a framework of ethical preparedness. First, we have the pre-event planning. We should integrate ethical committee into a medical planning process, develop a clear, predetermined, and publicly justified protocol for triage, resource allocation, and consist. This removes the burden of ad hoc decision-making from the frontline staff. And for the training and education, I hope that to move behind the clinical drill that we usually do in our hospital to include what is called ethical drill using complex scenarios, and to train all personnel on the ethical frameworks and protocol to ensure consistency. Support structure, implement a real-time ethical decision support, for an example, designated ethical lead for complex case in mass gathering medicine. Mandate and normalized post-event physiological debriefing to address moral distress and prevent burnout. The home take-away messenger for ethical practice. Mindset. Embrace, as we said, that shift from standard of care to crisis standard of care. Process. Triage is dynamic. Reassessment is moral imperative. Fairness, medical need is the sole determined. Its status is irrelative. Autonomy, when you can't ask for consent, earn trust through transparency and explanation for that patient. And finally, preparedness, ethical practice doesn't happen by chance. Plan, train, and support your team at all costs. This is my reference, and thank you for being here.
Thank you very much, Dr. Ahmed Al-Gabbani, for this talk. We are closing today and see you tomorrow. Thank you so much.